Good morning, everyone. I'd like to call the Subcommittee on Federal Impacts on Minnesotans and Economic Stability to order. Thank you all for joining us today as we continue to discuss how actions by the federal government are affecting our state. Last week, members of this committee traveled to Northfield to learn about the rising and devastating costs of healthcare and insurance and the effects that they're having on consumers and doctors, counties, and hospitals. This week, Minnesotans who purchase insurance on the individual market are beginning to shop for the plans they'll use next year. And they're getting hit with the sticker shock at the prices that they're seeing. Some Minnesotans and small businesses will pay 10% more for insurance next year, and some will pay up to 25% more. And that's if they can even afford it. Some can't and will go without insurance, hoping they make it through the year without illness or injury. Minnesotans who cannot afford preventative care end up in the emergency room after untreated conditions turn into urgent health risks. We cannot allow our emergency rooms to become a catch-all safety net. There are a lot of reasons costs are on the rise, including market pressure of more expensive treatment and drugs for aging populations. Other reasons are by choice. The decision by the Trump trifecta not to renew the enhanced tax credit will cost Minnesotans thousands of dollars, and cuts to Medicaid will push hundreds of thousands of Minnesotans into an increasingly unaffordable individual market. As we will hear today, these rising costs and dramatic changes threaten not only the individuals seeking or foregoing health care, but the entire medical system in our state. Without attention now and action soon, this trend threatens to bankrupt budgets from hospitals and clinics to small businesses and households. Members, in your packet, you'll find materials that are helpful to understand the issues we'll hear about today, including the presentations that various folks will be giving. We have a busy agenda, and I ask that members hold their questions until the end of each testifier block. And with that, I will call Commissioner Grace Arnold, Department of Commerce, to the table to testify. Welcome to the committee, Commissioner Arnold. Please introduce yourself for the record and provide your testimony when you're ready.
Great, thank you. So Chairport, Ranking Member Nelson, and members of the committee, my name is Grace Arnold, and I am the Commissioner of the Minnesota Department of Commerce. I'll just do a check to make sure we're, all right. I'm here today to discuss the private and small group insurance markets and how recently released rates will impact Minnesotans that obtain their health insurance in these markets. My presentation will provide a little bit of an overview of the private market, the 2025 rates, the impact of Minnesota's reinsurance program, and other factors that are driving the increasing cost of health insurance. Roughly 187,000 Minnesotans get their healthcare coverage through the individual market, most purchasing through MNsure. Most Minnesotans, sort of other than the O's, obtain their insurance through the employer market, through Medicare or medical assistance, which are the public programs. And typically, the individual market enrollees include farmers, independent contractors or gig workers, small business owners and some of their staff, and early retirees. So that mix is kind of what you should think about when you're thinking about the individual market. So now I'll turn our attention to our release that we are doing in 2025 for 2026 rates. Each year, the Department of Commerce and Health review plans and the rates that are submitted by insurance companies that offer on the individual and small group market. The departments must approve rates before plans can be sold. We also look at coverage to make sure it's in line with Minnesota law. And it's important to remember that the department does not set health insurance rates. Instead, we review the information that's submitted by the plans to confirm that the rates comply with state and federal law, that they reflect the benefits the consumer receives, as well as the insurance company's ability to pay expected medical claims. So I think the short way to think about that is we check the plan's work and confirm that the maths, which is the very technical way to say that our actuaries do a ton of work over the summer to make sure that the rates are justified. These approved rates are also not what individual Minnesotans will actually pay. The premiums vary family to family and person to person due to geography, age, and then any federal premium tax credits that lower costs for eligible consumers. So think about this as a more aggregated look at what the market is doing. So our 2026 rate changes we're seeing in the individual insurance market are on average a 21.5% increase. And again, I'll just enforce that the total rate increases will depend on the specific plan. You can see each plan has a different rate increase on average, what plan they're enrolled in, their age, and where they live. So these are gross premiums, net premiums. That's like what an enrollee pays on their bill. We'll see even greater increases due to the absence of what is called enhanced premium tax credits. This is higher because of proposed changes that happened this summer. For some reasons that the rates are higher than initially projected. So we do releases in the spring or the sort of early summer with proposed rates, and then the rates have gone up a little bit since then. And that's due to the passage of H.R. 1 at the federal level, other federal guidance, and then updated data and research from national research firms that project more adverse claims experience. Small group plans are plans where an employer offers insurance and if they have 50 or fewer employees. These plans are sold directly by insurers through brokers or agents and provide coverage to about 3.5% of Minnesotans. In this market, we're seeing an average rate increase of 14.2%, and we're monitoring these changes closely, particularly as the small group market continues to constrict. This is kind of a long-term trend in that market. The rate increases are really alarming and will have significant impact on Minnesotans with middle incomes. The hardest hit will include farmers, small business owners, gig workers, and early retirees. These hikes will push real people to make really hard choices like paying for health insurance or rent, a car payment, or things that would invest in their business like agricultural equipment. So what's driving our private insurance rates? Primary factors include a state effort to stabilize rates through reinsurance. That's something that I think we all can be proud of. It's a bipartisan effort and is something that is really stabilizing the market. Federal changes are leading to more market instability, and there are also increases in treatment options and costs that are driving the costs of the insurance. So I want to be clear what's not driving these changes. New state benefit mandates have a modest cost impact, but are not a primary factor in the rate increases we're seeing. And in fact, there were no new benefit mandates this year, so there are none that you can see in the rate increases from previous years. New benefit requirements are offset by defrayal payments, and they're not factored into rates in the individual market. So Governor Walz and the legislature were able to reach a compromise to extend Minnesota's premium security plan, or the state's reinsurance program, through plan year 2027. This program offsets a portion of an insurer's high-cost claims for care like cancer, premature babies, or diabetes care for somebody with multiple illnesses. We see a lot of folks who are just really, really sick in that program. Minnesota's reinsurance program has typically lowered rates by about 20%. For plan year 2026, the carriers are reporting that rates are 47% lower than our reinsurance program with our reinsurance program extension. And the department is still reviewing some of these assumptions. We focus on the rates people actually pay first, and then we look at the reinsurance estimates. But the anticipated market instability due to the expiration of federal tax credits is probably the key factor in that difference between what we sort of have as our estimate of the impact of reinsurance and the actual impact of reinsurance that we've seen this year. In Minnesota, we acted quickly to protect families and small businesses, and it made a big difference. But make no mistake, reinsurance is only part of the solution. The elimination of the enhanced premium tax credits at the federal level will substantially increase costs for Minnesotans who rely on the individual market for their insurance costs. The impact of those lost credits will be felt the hardest by people making over 400% of the federal poverty level, with MNsure estimating that 90,000 Minnesotans will see a cost increase averaging $2,000 a year. These increases will force many Minnesotans to go without health insurance, and what is particularly impactful for market stability is that the people who often choose to go without are younger, healthier people, and that leads to an unstable market because the risk pool is sicker and that has higher claims, and so then rates continue to go up. It's a real problem. In addition to the lost tax credits, there are other federal changes that are baked into these rates that include ending automatic re-enrollment, limits on annual open enrollment periods, and restrictions on special enrollment periods, all of those just make it harder to get coverage. And then what we see is that younger and healthier people tend not to go through the hurdles that they need to get to maintain their insurance. Most importantly, health insurance rates are increasing because healthcare is becoming more expensive every year. There are new prescription drug treatments, personalized cancer treatments, and specialty medications for rare and genetic diseases that can be life-changing but are very expensive. People are also growing older and sicker and are more frequently using healthcare services. And I think it's important to note, this is not obvious from a lot of the information, but the individual market is a little older than just as a group than other private health options. And that's, I think, mostly because there are people like early retirees, and there's a set of folks who aren't yet eligible for Medicare but don't have access to employer-sponsored insurance, and they tend to be in this market. There's also evidence that contracting with providers is more expensive as we see increasing consolidation in the market, higher staffing costs, and inflation for the cost of treatment supplies. Challenges accessing primary care is another area of concern that we think a lot about. That leads to treatment delays and reliance on really expensive sites of care like emergency rooms or urgent care centers. And we're also seeing problems with adverse selection in the small group market. So we're talking a lot about the individual market today, but we're also seeing adverse selection in the small group market, which means that a relatively low number of people on a small group plan, when one enrollee gets really sick, it often pushes the group to join the individual market because it's cheaper for them to do that. The rate increases are concerning, but it's really important to remember that Minnesotans should explore options. You can find more information about the rate increases on the department's website. Open enrollment on MNsure begins on November 1st. I know MNsure is coming today, so they can talk all about the shopping experience. But this is the best place to maintain coverage and shop for insurance options that meet your needs. So thank you for your time. I'm happy to answer questions now or later.
Thank you, Commissioner. Members, because the Commissioner has a hard stop at 10:30, we'll go to questions for her now if folks have questions. Senator Nelson.
Thank you, Madam Chair. Commissioner, thank you for the presentation. There's a bit of good news in there. There's also a lot of concerning news in there. And I had one question first, and then maybe just a few comments. It's so unusual to see that usually the small group plans are the most volatile, and they have the highest rate increases, maybe because of the small pool over which to share the risk. But in this case, it's very, I'm just curious why it is that our big plans are seeing these huge increases, 30.76% increase at Medicare, 27.48% at UCare, Blue Cross Blue Shield, 18.7% increase, Health Partners, 13.31 to 19.15%. And then, of course, the small group plans, a 14% increase across the board. Why is that this is really unusual? Usually it's the larger pools that see the highest rate. So what's going on here?
Commissioner.
Chair Port and Senator Nelson, thanks for the question. So it's because there's so much instability in the individual market, and that's largely driven by federal policy. So it's the expiration of the tax credits, the additional tax credits that have been in place. There are a number of administrative things that the administration is doing that make it harder to get coverage. And so then what the plans expect is that fewer people will be in the market. The people who will opt out of the market because it's too expensive will be younger, healthier people, and so they're anticipating that the population in the individual market is going to get a lot sicker as a whole because younger people will be dropping out because of all of these barriers to coverage, either financial or administrative.
That's an interesting comment. Those tax credits, you're looking ahead as if the tax credits would expire. You're assuming that they do, even though there's been great bipartisan support to continue those tax credits. Not just part of the continuing CR, but as has always been done, after the CR, let's work on these things. But these projections are assuming that the tax credits are no longer in place. Is that correct?
Commissioner.
Chair Port and Senator Nelson, yeah, so current federal law, the tax credits expire, the additional tax credits expire at the end of the year. So plans make rates based on current law, not based on speculation about what might happen. So these are baking in the current law, which is that the tax credits expire at the end of the year.
Sure. Madam
Senator
Chair.
Nelson.
Thank you, and thank you for that explanation. I think that's very important. I'd also like to see the projections, should it continue at its existing rate, much like the CR just continues things at its existing rate, which are not the pandemic rates, but the pre-pandemic rates. So would you be able to provide that information?
Commissioner.
Chair Port and Senator Nelson, we didn't specifically collect like a second set of rates in case they were extended. We can provide you in follow-up a little bit of information, but we don't, and the plans can speak to how much work that would be to do a second set of rates, but those are, we couldn't do the exact analysis that we have here without the tax credits. We can give you a little bit of information though in follow-up.
Thank you. I think that would, Madam Chair, thank you. I think that would be helpful because typically, well, I have one other further question. I just want to make sure I understand it. So your analysis, which is that all the tax credits go away or just the pre-pandemic elements of the policies?
Commissioner.
Senator Port and Senator Nelson. So great question. So there are tax credits that have been in existence since 2014 when the Affordable Care Act was passed. Those won't change, and our analysis under current federal law that is expected to be in place in 26, absent any other changes, those credits will continue. The additional tax credits that were passed during COVID are what are set to expire. So current law, those won't be available to Minnesotans, and I think you'll hear from MNsure the impact of those to people. The rates that we reviewed this year are taking into account the fact that those will not be available.
Okay, so Madam
Senator
Chair,
Nelson.
just to be clear then, your information assumes that the COVID rates are not extended.
Correct. That's,
All
yeah,
Commissioner.
Senator Port,
Thank you.
Senator Nelson, sorry. Correct. That's current federal law.
All right, thank you. I just, in looking at the rates in general, how do you think the tax increase that the 2025 legislature passed on managed care organizations, how that increased tax, I think it was about $549.4 million in 28 and 29, and in 26 and 27, it was over $342 million. So those are pretty huge expenses now that are placed onto our health plans. How do you think that impacts these increased rates?
Commissioner.
Chair Port and Senator Nelson, these are rates for the individual market, and there are rules about the way that you can't put costs and public programs into the individual or small group market. They need to be based on the market that you're selling to. So they're not in these rates.
Senator Nelson.
Thank you, Madam Chair. Well, it would defy logic, though, to think that increasing costs of, goodness, nearly $1 billion on our managed care organizations would not show up in costs somewhere. So I'm not exactly sure where we would be seeing those, but I think we must not lose sight of the fact that the legislature increased the costs on our managed care organizations by about $1 billion. I think there's something to dig into there and see how that has impacted the higher rates that we're concerned about.
Commissioner, I have a question. If I know that, the plans and the work at the Commerce Department takes months to do to get to what these plans, what the rates are, and then your department to verify them, that they're justified. And that's been going on since, presumably, since the bill passed in July. If now, in such a short period of time at the end of the year, if there is an agreement to reinstate those tax credits or to reinstate some of the Medicare benefits that will push people into these markets. What would that process look like to readjust the rates? Or is this what we've got?
Yeah, Chair Port, thank you for the question. So we actually started a review in May, so well before our proposed rates didn't include the impact of HR 1. So it's about a 6-month process to review the rates and make sure that they are in line with law. I kind of outlined what we did. So, you know, timing is everything. I think we'd take a look if the tax credits were passed, it'd be a really big challenge to try to have plans redo rates. Then there is a process to make sure that that plan information gets into, we collect it in a way that is not consumer intelligible. That's what MNsure does, and they turn those into the actual shopping experience, and that is a process that generally takes us some time to do. I think anytime you have something that is so close in timeline, you increase the risk for errors, you increase the burden on consumers because sometimes there's conflicting information that gets out, and all of that would get baked into, anything that we would have to do. And so I think that it is already well past time. People would get an impact because I talked about we're doing the rate part, and if the tax credits were extended, then people would get the benefit of that for sure. And MNsure will talk about the really significant benefit that the tax credits provide to Minnesotans. It is an exceptionally challenging circumstance to be in.
Thank you, Commissioner. I know you have to get out of here, so we'll let you go, but we appreciate your time, and we will move on to Libby Callum from MNsure.
Thank you.
Welcome to the committee, Ms. Callum. If you would introduce yourself for the record and present your testimony when you're ready.
Thank you, Chair Port, Ranking Member Nelson, members. Thank you for having me here today. I'm Libby Cullum, CEO of MNsure, Minnesota's official health insurance marketplace. I'm gonna wait just a second to get our slides up. Sorry, Pete.
Yeah, I'm sorry.
You are fine. Okay. All right, so each year, MNsure helps thousands of Minnesotans apply and enroll in coverage. I've been asked here today to talk about the impacts of federal policy changes for those Minnesotans. The most immediate of these impacts, of these changes, will be the effect most consumers, will affect consumers the most. It is the scheduled sunset of the enhanced premium tax credits at the end of this calendar year. So I'll be spending most of my time on that change. And then after that, I will walk you through what the consumer experience is when they go to shop for coverage at MNsure.org. This slide, the next slide, yeah. This slide does not contain a comprehensive list of all federal policy changes from the One Big Beautiful Bill Act or the recent federal rule. We've selected these examples, pardon me. We've selected these examples to illustrate the wide-reaching impacts on eligibility, affordability, and access. I will briefly describe these policy changes for the committee. So first, we are looking at the end of eligibility for DACA recipients. So as of August 2025, people enrolled in the Deferred Action for Childhood Arrival program are no longer eligible to purchase coverage through MNsure. Next, we have seen an increase to the out-of-pocket maximum limit, which means higher out-of-pocket costs for our enrollees. The Centers for Medicare and Medicaid Services, CMS, increased the allowable maximum out-of-pocket amount by more than 15% to $10,600 in 2026. This is the largest increase since the ACA marketplace first launched. As we'll discuss in just a moment at length, the enhanced premium tax credits will expire at the end of this year. And we'll also start to see other mandated changes in the coming years, like a shorter open enrollment period. This year, our annual open enrollment period will run from November 1st through January 15th. But beginning with plan year 2027, Marketplaces must end their open enrollment periods no later than December 31st. Also, beginning in Plan Year 2027, we will need to implement new limits on tax credit eligibility for many lawfully present immigrants, meaning many lawfully present immigrants will no longer have access to advanced premium tax credits. Finally, new red tape will end automatic re-enrollment for consumers beginning in Plan Year 2028. At that time, all enrollees seeking premium tax credits will need to take extra steps to maintain their eligibility, effectively ending auto renewals of coverage. These federal policy changes will make private health insurance harder to access, afford, and maintain. And taken together, when all of these changes are in effect, we estimate that up to 45% of MNsure enrollees could drop coverage. Substantial rate increases combined with the end of enhanced premium tax credits mean that many MNsure consumers will see steep premium increases in 2026. Congressional action could shield consumers from feeling the impacts of rate increases, but without the extension of the enhanced tax credits, costs will go up for nearly 90,000 Minnesotans, and over 19,000 will lose access to all financial help. There's been a lot of media attention to the impacts for people who earn more than 400% of the federal poverty level. Those folks will experience what is often called the subsidy cliff. What I can tell you is that enhanced tax credits improved affordability for consumers across the board. Many individuals and families with incomes below that 400% threshold will see cost increases because the amount of financial help they get will be dramatically reduced. Here are two examples from different parts of the state. Let's look at a family of 4 in Freeborn County, so Albert Lee. They're earning $105,000 per year. That's 325% of federal poverty level. And they're enrolled in a bronze plan. Currently, in 2025, they pay $143 per month after their tax credits. If they select the same plan for 2026, they will still receive some tax credits, but their net premium will more than triple to $490 per month. Paying $347 more each month, or $4,174 annually, is an increase of 243%. A married couple, both aged 40, in Marshall County, earning $69,000 per year, also at 325% of the federal poverty level, enrolled in a silver plan. They paid $423 per month in 2025 after their tax credits. If they select the same plan for 2026, again, they're still eligible for some tax credits, but their net premium will jump to $725 per month. They'll be paying $302 more each month, over $3,600 annually, which is a 71% increase. As I've said, some MNsure enrollees will lose access to financial help entirely. So, for example, people with incomes above 400% of the federal poverty level will lose all access to tax credits. That's about $62,000 for an individual or $84,000 for a couple. And I'm going to walk you through two examples of couples who aren't eligible for Medicare yet, so they're just too young for Medicare and rely on MNsure for affordable coverage. So we've got a couple in their early 60s in Mankato. They could be seeing their premiums go up by more than $1,500 per month, from under $500 per month today to $2,000 per month next year, a staggering 322% increase in what they pay. Next year, this couple would pay $24,000 just on monthly premiums to stay enrolled in their bronze plan. Their deductibles and copays would be on top of that amount. A couple in their early 60s in Bemidji could see their premiums go up by $1,200 per month, from under $500 per month today to $1,700 per month next year. That's a 265% increase in what they pay for the same reasons that I described above. This couple would be paying about $15,000 more next year on monthly premiums just to keep their access to health care. In short, our main message to consumers is that plans and prices change every year, but this year there will be big changes for many. We are actively encouraging all consumers to explore their plan options for 2026, even if they've been in that same health insurance plan for many years. We want them to come back and shop and compare their options. MNsure certified brokers are also available to work with consumers who are interested in comparing plan options and determining the best fit for their and value for their families. Next, I'd like to walk you through the consumer experience and share with you what they see when they come to MNsure.org. So before they fill out an application, Minnesotans can use our Shop and Compare tool to check if they may be eligible for free or low-cost health insurance through medical assistance or Minnesota Care, or if they're eligible for advanced premium tax credits, which lower the cost of their private health insurance. This tool provides a fast, convenient way to understand options and make informed decisions. With the Shop and Compare tool, consumers can quickly review the health plans that are available where they live, and they can get a clear estimate of out-of-pocket costs. Next slide. I'll use a scenario here, again, to demonstrate what folks might see. So let's take a 30-year-old gig worker in Austin, Minnesota, who doesn't have access to employer-sponsored health insurance, and his income varies month to month, but he does expect to average or make about $39,000 in 2026. He just needs to put in 3 pieces of information to get an estimate: where he lives, and if we go ahead here a little bit further, okay, there we go. Where he lives, so he's included the Austin area zip code and Mower County, who's in his household, and his annual income of $39,000. On the next screen, he can get a quick estimate that he's eligible for about $315 per month in advanced premium tax credits. In the next slide, so with this estimate in hand, he can either go directly to view his plan options, or he can answer a few additional optional questions that will help him make an informed choice based on his specific needs. So the optional questions enable consumers to filter plans based on what's important to them. For example, if they'd like to make sure a preferred provider is in network, or a specific prescription drug is covered, or compare plans based on the amount of health care they expect to use next year, he can do that. At any point, he can skip ahead to view plan options. Next slide. So this is a small snippet of what he sees when he's viewing plan options. In practice, a consumer will see all available options in their area and the net premium that they can expect to pay after advanced premium tax credits. Consumers can sort plans, apply filters, and compare options side by side, making it easier to fully understand the benefits provided. This is similar to an online shopping experience where maybe you're shopping for a pair of jeans or a sweatshirt and you just sort from the highest to lowest price or lowest to highest price. It's a similar experience to that. On the left side, you can see some of the options consumers can use to narrow their choices. For example, you can sort by monthly price or yearly deductible. You could apply the HSA eligible filter to find plans that work with a health savings account. This next slide is just an overview of what I just covered, so we'll skip that one and go to the next one. So earlier this week, we launched plan previews for 2026. Which means consumers can come to MNsure.org right now and use the tool to get a jump start on their plan shopping. Consumers have 2.5 more weeks to do this window shopping before our open enrollment period begins on November 1st. Starting Saturday, November 1st, they can come to MNsure.org and complete the process to enroll in a plan. That's everything I have prepared today. I'll end with although the federal policy changes will create new barriers for Minnesotans seeking health insurance, MNsure will be here to help make sure consumers understand their options and have the information they need to make informed choices. Our commitment to our mission remains unchanged. we will do everything we can to ensure as many Minnesotans as possible maintain the security of health insurance. Thank you for the opportunity, and happy to answer any questions you may have.
Thank you very much. Members, questions? Thank you very much for your presentation.
Thank you.
Members will now turn to take a look at the federal actions that have lessened the accessibility to insurance while simultaneously making it more expensive. And for that, we'll have Professor Lynn Blewett from the University of Minnesota School of Public Health. Welcome to the committee, Professor. Once you're settled in there, if you would introduce yourself for the record and present your testimony when you're ready.
Thank you, Chairman Port and Ranking Chair Nelson and committee members. It's good to see you all, and thank you for inviting the university to present today. My name is Lynn Blewett. I'm a professor in health policy at the university, and I've also been involved with health policy for the state of Minnesota for more years than I want to count these days, but to the beginning of Minnesota Cares. So I have a lot of experience with Minnesota state policy and have worked with other states on health policy, primarily related to access and coverage. I've got a lot of maybe a little more detail than what has been presented, and I will go through them quickly, and we can come back and ask questions if there are questions. I felt like it's important to have some of the weeds on the table, and we can come back and dig into any one of these, but I thought it might be good for level setting. So this is a nice pie chart on the distribution of coverage of where Minnesotans get coverage. And Minnesota is one of the states that has the highest coverage under employer-sponsored insurance. It's about 54%. And we have one of the lowest rates of uninsured, which is it's about 4.3%. And if you take out Medicare, we're under 4% at about 3.8%. The private sector is about 60% of coverage. Public sector is about 40%. When you look at the financing, it's about half and half. And I just want to point out that the Department of Commerce regulates the fully insured market, and so it's just this small piece of the total coverage distribution in the state. And so the Commerce regulates the individual market, the small group, and then the fully insured large group market. So when Commerce makes a change or adds a mandate, they don't affect any of these other coverage programs. They just affect this small part of the pie. I want to touch on the Affordable Care Act a little bit because a lot of these things are changing. And the key access provisions of the program were the Medicaid expansion, the federal premium tax credits that is highlighted today, and then health insurance market reforms. And I'd just like to note, prior to the ACA, the individual market was not subsidized at all. It was the only market that wasn't subsidized. And so people who are in the individual market purchasing on their own paid the full price of the premiums. And the average price today for individual is about $8,000. For family, it's about $25,000. So the premium tax credits went a long way in terms of affordability in the individual market and basically put the individual market on the same playing field as the other pieces of the market and distribution. So these are the essential benefits that were required under the Affordable Care Act. These are the market reforms that were required. These went into effect in 2014, so they've been on the books for over 10 years now. I'll just say that before the Affordable Care Act, many health plans did not offer maternity and labor delivery, did not offer or carved out mental health and behavioral services, carved out prescription drugs. And this is a new service, pediatric services for oral and vision care. So any product offered in the individual market has to provide these services under federal law. The other provisions related to the rating and how plans can rate. And again, there were significant limits on how plans could set the rates, which helped to keep the prices low. So there's no rating on health status or gender. There used to be differences. If you were sicker, you'd get a higher premium. If you were female, you'd get a higher premium. And then the age rating, which is now limited to 3 to 1, which just means you can't charge a 60-year-old more than 3 times what you charge a 20-year-old for the same plan. So it basically provides a guardrail on the rates across age. There's no pre-existing exclusions, and many who are around during our high-risk pool remember that a lot of health plans would carve out pre-existing conditions, so they would fill out a health form or maybe have a health assessment. And if you had a pre-existing condition, breast cancer, maybe migraines, those might be carved out for 6 months or 12 months, even up to 18 months, and not have any coverage for those until that period of time. That is no longer allowed in the insurance market. I'll just say I crossed out this individual mandate because there was part of the ACA was a mandate that you would have to have health insurance coverage or pay a penalty through the tax code. That was eliminated in the Tax Cuts and Job Act of 2017, took effect in 2016, and I'll just point out that 6 states have their own individual mandate, and they do it the same way. If you don't have health insurance, there's a penalty that is paid through the tax system when you're filling out your taxes and show proof of insurance. And that penalty goes into the coffers and is used for primarily healthcare access initiatives. I'm not going to spend too much time on this, except these are the details of the enhanced premium tax credit and the initial premium tax credit, which is on the right. And the thing I wanted to point out here is that the tax credit is based on your income, and it's capped on a % of income. So if you look at the enhanced premium tax credits, those under $17,000 a year, that's 133% of the federal poverty level, that's an income, would pay, they're not paying any premium now, and if it goes back to the initial tax credit, they would pay 2% of their income. And as your income increases, that cap increases. And so at $51,000, we're up to 8.5% of your income is what the cap is limited to the premium that you would pay. And when it reverts back to the initial premium tax credit, those above 400 would no longer be eligible for a subsidy. So I think the advocates are very concerned about this above 51% of federal poverty, including those like 60 to 64 waiting for Medicare who may have some income, but they're not eligible for the Medicare program yet, and so they're paying the highest premiums in the market. And then also these folks who are paying zero, those are, lots of self-employed, younger people, very responsive to increase in premiums, and will likely lose coverage and affect the pool. So Minnesota Care did do a lot under the ACA. We expanded Medicaid to 38% of the federal poverty level. We established the Minnesota Care program, developed MNsure as a state-based exchange, and then used the ACA 1332 waiver to develop a reinsurance, and we were one of the early states to do that through bipartisan efforts. I just wanted to show this chart, and this is one of my favorite charts, which I have to update every once in a while, but this just shows that these are the way that the federal government flows to the states in terms of subsidies. So if you look at the 38 states that have expanded Medicaid, if you're in those states, you're Medicaid up to 138% of poverty, and then you're eligible for the premium tax credits in the marketplace, which is MNsure. Minnesota has this BHP, Basic Health Program, which we call Minnesota Care. There are 3 states who now have that BHP. It's a very tightly limited income eligibility, 138 to 200, but it basically is a Medicaid-like benefit. It has very low or no copays, low or no premiums, and serves a very important part of our coverage. And then when you go above 200%, you're eligible for the premium tax credits through MNsure. And then the 10 states that have not expanded Medicaid, just to make things complicated, their tax credits through the exchange start at 100% of the federal poverty, and anything below that, people in those states don't have coverage. So in those states, the poorest people do not have any access to subsidized coverage. The uninsured rates dropped significantly under the ACA. It had significant impact both through the Medicaid expansion, the subsidies on the exchange. There was a lot of money put into enrollment assisters and navigators to help people get enrolled. And these are the rates. Minnesota's dropped by almost a half, from 9.4% to 4.8%. And the rate for the United States were under 10%, which is a significant drop. And something, I've never seen this kind of chart where you see a policy implementation and a significant impact. People have asked me about premiums. Are premiums high in Minnesota? And I looked them up. And actually, we're kind of right in the middle. We ranked 33 of all states. These are 2024 premiums. In the individual coverage, these are the 5 highest states, the 5 lowest states. The average is about $8,500. Minnesota is just under the average. And I or one of my colleagues can come back and talk about affordability. There are lots of issues with deductibles, co-payments, increasing. Just didn't have time to do that today. This is the premium increases for 2026 for marketplace insurers. This was a survey that was done of about over 300 marketplace insurers and the distribution of their rate increases. And I would just say Minnesota at 22% is kind of in the middle, but maybe a little higher than the actual middle point in this nicely figured bell curve. But we're not the highest, we're not the lowest, kind of right in the middle. So the impact of federal changes includes, the not extending the enhanced premium tax cut, but you have to take into account also the cuts to the Medicaid program, and I just want to slip this in here to not forget that. It's almost $1 trillion over a 10-year period for the Medicaid program, and then the expiration of the premium subsidies. And there's some estimates that Minnesota could lose up to $154 million just in fiscal year 2026, and an estimated increase of uninsured of 170 to 180,000 individuals could lose coverage. And those primarily are from work requirements, redeterminations, and new verification requirements. The concern of this is that kind of money is a huge disruptor in the entire healthcare system. It's not just people losing the Medicaid coverage, it's dollars that are flowing through enrollees to providers, and it affects the whole country in terms of disruption. So there's concern about capacity constraints around the healthcare system, particularly in rural areas where it's not a lot of volume. Increase in out-of-pocket costs as employers face increasing costs. They shift more of those costs onto their employees in terms of high deductibles. We're already a state that has very high use of high deductible health plans. And then increased complexity from multiple disruptors, which basically increases consultants, increasing roles of private equity, and lots of changes happening in the healthcare system that we are thinking about, but nobody really knows what's going to happen. We just know it's going to be a huge disruption. So what does the evidence tell us? For individuals who lose coverage, losing Medicaid coverage and simply moving on to Minnesota Care is not necessarily an easy switch. There may be a special enrollment period. You have to know about it. You have to know where to go. You have to know what kind of information to include. There's new requirements for income verification, for citizenship verification. And we all know that this will lead to delayed and forgotten care, greater ED use, greater medical debt, and consumers caught in this administrative complexity of the system that's rapidly changing. For providers, we see worse financial margins, increased risk of closure, particularly in rural areas, and specifically concerned about the safety net providers, including community hospitals, HCMC, the federally qualified health clinics, which are limited now in terms of the patients they can see. For payers, there's administrative burden from churn, people going on and off programs, moving between programs, and then also their need to verify eligibility, residency, and other things. That information and data is going to have to be built out. And then spillover effects into other lines of business. So you may be a health plan that offers individual small employer, and maybe you have a self-insured plan, but that it all contributes to your bottom line. And how that revenue is going to move across those programs is not clear. And then implication of costs for the state Medicaid program in terms of its eligibility redeterminations, which are required every 6 months, doing exemptions for the work requirement, doing the work requirement, verifying it, all that will require new data, new forms, new personnel, and a strain on federal Medicaid at a time when programs are being cut. So what states are doing, I'll just mention a few things, and the check mark means Minnesota's already doing this. So several states have moved to a state-based marketplace. You can opt into this federal marketplace, but there have been 3 or 4 states that have moved to state-based marketplace, so you have a little more control at the state level. At least 6 states already have added state dollars to enhance the federal premium subsidy, and states are looking to backfill. So when the federal subsidy goes away, can you backfill for that federal subsidy? There's several states who are doing it, and 6 states already add on to the federal subsidy, and so they're in a little better position than states who haven't done that. Several states are doing the reinsurance, and as Commissioner Arnold showed, that it stabilized premiums in the individual market, and it's so important right now to continue that. And then 16 states have required filings of 2 sets of rates, so one without the enhanced, one with the enhanced. Minnesota is not one of those, but there are states that have done that, and may be in a better position to move ahead if the tax credits are either extended or not extended. They have 2 rates on the books right now. And then states are looking at public options offered either on the marketplace or a standalone plan. Washington is the first state who was out in 2021. Colorado has an option 2023. Nevada and Minnesota have studies underway. There are mixed results on the public option, but again, states are making efforts to think about what they can do to get people covered and keep costs under control. So there's a lot more to talk about. I will just say that my remarks are my own views as an individual faculty member and may not represent the university or my funders, and happy to take any questions at this time.
Thank you very much, Professor. Members, questions? Senator Nelson.
Thank you, Madam Chair. Thank you for the presentation. Appreciate that. Right at the end, you mentioned, I think, what I was asking for, which was that there are 16 states that are filing 2 sets of rates, one with the extended COVID-related premium tax credits and one without. Do you have it, and I'm just wondering, I don't know if you have any indication about this, but why has Minnesota not taken that thoughtful approach? Are there reasons to not take that approach of having both?
Chair Port and Ranking Chair Nelson, I can't answer for the department, but they do have rates that have reinsurance and not reinsurance. And so I'm thinking maybe at that time, when they were filing rates in the last couple of years, they've presented rates in both ways. And so adding yet another rate maybe was just more complicated. I'm not sure.
Senator Nelson.
Thank you, Madam Chair. Well, I have a lot of confidence in Minnesota. I think if other states could do that, I think certainly our state has the capability to. Thank you so much.
Senator Mann.
Thank you, Madam Chair. Thank you, Professor, for being here. We heard from the last testifier that a lot of people are going to lose their health insurance. We heard that DACA recipients who oftentimes have never set foot in another country, aside from perhaps their early childhood, and who oftentimes only speak English and are Americans, we're going to take away their health insurance. and we are going to take away the health insurance of people who are here lawfully, lawful immigrants, right? We keep hearing, oh, illegal, illegal. Lawful immigrants that we're going to take away their health insurance through this federal bill. We're going to end automatic enrollment, and we are going to cut the open enrollment period. So on top of that, we're going to increase the premiums for Americans across the country, right? Someone paying $400 a month right now is going to pay $700 a month. They're not going to afford that. You can't afford that. Or up to $2,000 a month. We can't afford that. And so people are going to lose their health insurance. Historically speaking, when we take away people's health insurance, and the goal is, right, the rhetoric we're hearing behind this is going to decrease the cost of healthcare. This is about cost. This is about fiscal responsibility. So historically speaking, when we take away people's health insurance, do we decrease the cost of healthcare?
Professor.
Chairman Port and Senator Mann, no, we don't. I mean, people still need healthcare services. And so people who are undocumented or DACA recipients or here legally under the 5-year ban for Medicaid coverage are still going to need services at some time or another. And this includes prevention, this includes chronic disease. And so where they end up going is either HCMC, the federally qualified health centers provide some, not all specialty care, but some prevention services. There's concern about funding for those community health centers not being able to see residents from other countries. And then also, people delay care, they forego care, they wait till the absolute last minute, and then they end up in the ED, which is the absolute worst place for them to be and the most inefficient place to be. So all those costs are borne by the healthcare system, and we'll see an increase in uncompensated care on community hospitals and how we pay for that and who pays for that. Hospitals cannot turn away people who show up for emergency medical care, regardless, it's a federal law if there's an emergency. And so, you know, we can cut all we want, it doesn't make people healthier.
Senator Mann, follow up?
No, thank you, Professor.
Senator Rest online, we'll go to you next.
Sure, my picture is not showing because I'm sitting right there, but it's showing, I mean, I don't know what happened. But anyway, so I apologize for that. I am here and I am watching, and a little bit along the tack that Senator Mann was taking. So millions of people are going to lose their health care. And if they get any health care at all, it's going to be probably substandard or emergency care. It's going to be in overloaded emergency rooms. I would like to know in your research studies if you have asked for actuaries to indicate and to give, because they measure risk. Obviously, that's their big thing, and it's a big thing with regard to healthcare. How many people are actually going to die from their studies because of the actions of the federal government in cutting all of these health programs? I am sure they have an actuarial risk assessment of how many Americans are going to die. Do you have access to that information? How many are going to die?
Professor.
Chair Port and Senator Rest, I have not seen those numbers. And I think, you know, considering HR 1 was just passed in July, and there are a lot of moving components there, you know, I do know that lack of health insurance does increase the burden of health status, and also increases mortality. So I could find those numbers from past studies and look for the mortality rate. I don't know that offhand, but I know it does increase the possibility of increased mortality and also risk burden.
Well, thank you very much. I'm very interested in being able to tell my constituents how many of them and their family members should expect to die as a result of the federal legislation, especially if the government is going to, and does it increase exponentially as the shutdown continues? This is, in my mind, a life or death measure that is, and I can't find the way to flip the screen, sorry. But I am truly incompetent in some of this stuff. But I do worry about them, and what are they going to do? Who's going to cover funeral expenses? What's going to happen to all these people that are going to die as a result of the actions of the federal government? And I'm going to mute myself now and try and see if I can figure out how to correct my screen. Thank you very much.
Thank you.
Thank you, Senator Rest. Thank you very much, Professor, for your information. We're grateful for your participation today. Members, we will now move to some voices from our hospital systems to hear how they're preparing for 2026 and the anticipated impacts this will have on how care is provided. If Mary Krinke and Joe Schindler can come up, you're already doing that. Welcome to the committee. If you would both please introduce yourself for the record and then present your testimony when you're ready.
Thank you, Madam Chair and members of the subcommittee. For the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. And I have with me today my colleague,
Joe Schindler with the Minnesota Hospital Association.
And Joe's our Vice President of Finance, and we are going to get into some of the numbers that we have estimated, both in terms of the loss of the premium tax credits as well as the impact of H.R. 1. I want to talk a little bit about both the inactions of Congress as well as the actions of Congress. And to Senator Nelson's point, I just want to comment, we are extremely hopeful that perhaps a deal can be reached and that these subsidies to help people purchase their insurance on the exchanges will come to fruition. But if that does not happen, the hospitals have estimated what the loss of this coverage will mean to both the hospitals as well as to our communities and to individuals. So as was also mentioned, hospitals are the only provider that's open 24/7, 365 days a year, and will see anyone in the hospital emergency rooms regardless of their insurance status or their ability to pay. Just as a reminder, last year, 40% of our hospitals had negative operating margins, so we are not in a very good financial position right now to absorb any additional losses. I want to start out with the tax credits, and the other speakers have mentioned the specific numbers, and boy, that presentation from MNsure was really revealing about how much of an increase this will be for individuals. It's really hard to predict the exact number of individuals who will choose or simply not be able to afford their insurance. We are going with numbers from DHS, and DHS estimates that it'll be about 60,000 Minnesotans who will lose their ability to purchase health insurance because they simply can't afford it. So for our analysis today, we're using the number 60,000. I recognize that that number could change based on if things change in Washington. This will impact rural Minnesota to a greater extent than the metro area, primarily for two reasons. Number one, farmers are usually purchasing their own insurance. And number two, the metro area has more large employers that provide insurance for their employees. And in rural Minnesota, you have more small businesses that frequently can't afford to do that. So this will impact greater Minnesota more so than the metro area. This no doubt will lead to increases in charity care for hospitals, as well as a loss in payments that we receive from those individuals who do seek healthcare services. So, but before we get into the numbers, though, I do want to talk about what it means to a community and to a hospital when there's increases in charity care. And to be clear, the last thing that a hospital wants to do or their board of directors wants to do is to close a hospital. So that is the last resort. But in the interim, hospitals, when they're faced with financial challenges, will be forced to reduce services. And unfortunately, we're already seeing that in some communities. So what they do is they evaluate which services they're currently subsidizing at an operating margin loss, and those frequently are, and you've seen this before, mental health services, OB services, dialysis, subsidies to ambulances, and closing clinics. And that's been the recent occurrence that has happened with closing of clinics. So when that happens, it doesn't just impact the hospital, it's really devastating to the community. And I think that one message that's really been missing, those services close, it doesn't just impact the Medicaid population or the uninsured, it impacts the whole community. When those services go away, they go away not just for those on Medicaid, the whole community loses those services. And it's not just the people who are using those services now, it's the people who need to use those services in the future. So it also was talked about, what does this mean for the individuals? And quite frankly, it's really, really hard on these individuals. They're going to have to drive a longer distance, which in rural Minnesota, it could be another 100 miles. There's also fewer providers, so maybe you have to wait longer for your appointment. Maybe now you're waiting, instead of 3 months, you're waiting 6 months to get in to see a provider. So this adds, as it was mentioned, this adds to the cost of providing care because the individual has delayed services, and it also means they suffer from deteriorating health. Maybe they can't work their job anymore. So there's a lot of implications beyond just the walls of the hospital. So I wanted to mention that first before we dive into the numbers. So I do want to share some numbers. We've looked at both the impact of losing the tax credits, the premium subsidies, as well as H.R. 1. And these numbers are not in isolation. So the charity care, I'm sorry.
Madam Chair, could I
Senator
just ask a
Nelson.
brief question so I make sure I understand all the good information that you're going to be bringing? Is your information losing all the tax credits or just the COVID-related tax credits? I just want to be really clear on that.
Thank you, Senator Nelson. What we have done is we're using the number and recognize that number, we really don't know exactly who's going to drop purchasing on the exchange. We're using the number of 60,000 because that's the number that DHS has said. Those are the number of individuals who will choose or be forced to, I want to be clear, not be able to afford their insurance on the exchange. So our analysis, and we'll get through these numbers, is based on a number of 60,000 for losing their coverage on MNsure. Then we're going to get into H.R. 1 next, okay? So that number could certainly change. So I want to recognize that. But our financial estimates are based on 60,000 people losing their insurance that they currently have on MNsure. So we've estimated, and Joe will go through the numbers here in a minute how we got there, but we're estimating that charity care in hospitals will increase by $115 million. $115 million annually for the individuals who purchase their insurance on the exchange. We also are estimating a loss of payments to hospitals of $161 million. That is a conservative number because we took 30% of the overall healthcare spending. Hospitals may actually be more than 30% of the overall healthcare spend, but that's the number we're using. So that comes to $276 million annually for the loss to hospitals from people losing their coverage on the exchange. Now, that number is not in isolation. We also have what's going on with H.R. 1. So DHS has estimated that under H.R. 1, 140,000 individuals currently on Medicaid would lose their Medicaid eligibility primarily because of work requirements or the 6-month redetermination, sort of all together the different aspects of what is in H.R. 1. 140,000 Minnesotans would lose their current coverage. So we've done some estimates on that, and that is pretty significant. It would be about $269 million a year in charity care increases and $354 million a year based on lost Medicaid payments. So combined, that would be about $623 million a year. Now, that does not start until 2027. So we are hopeful that there can be improvements in technology and this 6-month redetermination. We just met with the counties this morning. We are doing everything we can to see what we can do to handle this 6-month redetermination. It's going to be very difficult for DHS, the hospitals, and the counties, but we're working on that. But if nothing changes, and it's 140,000 people that lose their coverage, it's a hit to hospitals somewhere around $623 million. I want to be clear before I turn this over to Joe that the nonprofit hospitals and health systems in Minnesota are already in a pretty precarious position. So we know that we will be forced to close additional services if these cuts come to full fruition, and we're going to need your help. We can't maintain the level of services we have 24/7 unless something changes. So with that, Joe's going to walk us through the numbers, and I hope you all got a little handout sheet that was passed out. Thank you, Madam Chair.
So, Madam Chair, I realize we're running a little short on time, but I'll just take 2 or 3 minutes to go through this front and back one-pager.
Thank you.
That is dense with numbers. And if I start on actually page 2, which is the ACA, Individual Market Subsidies Impact, what we've done is, again, we're using 60,000 people that would disenroll from the Affordable Care Act programs, individual coverage, excuse me. And the way, what happens to those patients? Where do they go? Quite frankly, most of them will end up in the hospital emergency room. So we're estimating about 40% will be seen in the emergency room with an average cost of about $2,500 per encounter, leading to about 60 million of that total, of the total number that we came up with. And then some portion of those patients will be admitted to the hospital for inpatient care at an estimate of $9,800 per stay, which adds up to $53 million statewide. And then some will be seen in clinic for a total of around $2.5 million statewide. So those are the numbers that comprise our $115 million in charity care costs that we expect to see if Congress doesn't act and if these premium tax subsidies aren't restored. In addition to the revenue
Mr. Schindler,
loss.
can I interrupt for just 1 second about that? Is that sort of spread evenly across the state? Do we know if there are areas that will be impacted more severely than other areas?
Yeah, Madam Chair, that's a great question. We think much of this could be more hit on in rural Minnesota, partly because the individual market is focused on individuals, farmers, small businesses, whereas in the metro we have larger businesses, more group coverage. So for that reason, we think this hits harder in rural areas.
Thank you.
If we go to page 1, reversing order here and going to the impact of H.R. 1, we're talking about Medicaid cuts. And there again, we're using DHS's assumption of 140,000 people estimated losing coverage. And this is annual too. I mean, it doesn't start till next year, but this will be year after year after year. And as Mary said, we have concerns about the state and county's ability to keep up with all the new re-enrollment requirements. But that said, we expect that about 40% of those newly uninsured individuals will show up in the emergency room at about $2,500 per encounter, for a total of $140 million worth of uncompensated emergency room costs, in addition to those that will be hospitalized in inpatient care at an average cost of right around $10,000, total statewide of $123 million. And then again, some people will be seen in clinic for follow-up or pre-hospital, and that totals $6 million. So that's where we get our $269 in additional estimated costs.
269 million.
Yes, what did I say?
$269.
Oh, sorry. In addition to, the revenue loss from Medicaid coverage of $354 million. Now, there is a cut that's happening as of today, and that is that the changes to emergency medical assistance, which was funded 90% by the federal government, has, as of October 1st, as I understand it, has been reduced down to 50%. And so that cut is coming immediately, and we assume, since it's hospitals that are generally using the emergency medical assistance program, that we will take most all of that cut, including as of today, that's $13 million annually, in addition to cost sharing. So putting co-pays on Medicaid individuals, which, by the way, was tried about, 10 or 15 years ago in Minnesota. It was a failure, and most hospitals had to swallow those costs. And so that's another $3 million on hospitals statewide. I'm really not getting into the Medicaid directed payment program that was intended to help hospitals restore some of these funding cuts that we already absorb in the Medicaid program, but those are being phased down over time. The program itself is being phased down, the assessment side as well as the reimbursement side being phased down to Medicare payment levels, which are below cost in and of themselves. The downstream effects of this, in addition to this, are under the continuing resolutions, Medicaid DSH program, the disproportionate share funding program, goes away. That means places like Hennepin Health, North Memorial, Children's Hospitals, and all those that do a disproportionate share of serving Medicaid residents, their funding will go down, effective immediately because of the DSH cuts. And then finally, as fewer people are in the Medicaid program, it will have a downstream effect on hospitals that qualify for 340B drug discount funding. Some of those hospitals will lose that ability to get lower cost medications for their patients. So with that, I'll pause for questions.
Thank you very much. I know we are hoping to later in the year do a deeper dive on rural healthcare and rural hospitals and EMS services in general. But just based on your understanding of where hospitals across Minnesota are right now, and based on these numbers, these seem terrifying to me. How many hospitals and clinics will we lose?
Well, I can say that 77% of the hospitals losing money are in rural Minnesota. I'll leave it at that.
Thank you. Senator Mann.
Thank you, Madam Chair. I just wanted to clarify one thing. We said that 60,000 Minnesotans will be priced out of healthcare, and another 140,000 will lose Medicaid. And we're going to cut the Medicaid days associated because of the federal bill. And on top of that, they cut emergency medical assistance by 50%. Is that correct?
That's correct.
Thank you.
Thank you very much for your testimony. We will hear now from a more sort of right in one hospital and the view from Northfield. Xander Abbott, the president and CEO of Northfield Hospitals. Welcome to the committee. Mr. Abbott, if you would introduce yourself for the record and then present your testimony.
Great, thank you, Madam Chair. Thank you, committee members. Appreciate being here. My name is Xander Abbott, and I'm the president and CEO of Northfield Hospital and Clinics. We are a small community hospital in rural Minnesota. We have 37 beds and 5 clinics. We sit right on the line of Rice and Dakota County, so we serve citizens and all individuals from Rice and Dakota County. I'm here today to provide more of a specific example of everything you've heard. Everything you've heard this morning aligns with what we're experiencing at Northfield Hospital and Clinics. In addition to the challenges that we see around the Medicaid eligibility reductions, which we anticipate will be a 1 to 3% reduction in our net revenues. We also see challenges with the premium tax credit expiration, another 1 to 3% reduction in our net revenue. We're also interestingly positioned as a small community hospital in the sense that we're just big enough that we're not qualifying for critical access hospital status. So critical access hospitals are those that are fewer than 25 beds and more than 35 miles from another hospital. We're a little too close to our colleagues in Faribault and Burnsville, and our census is a little bit too high. So as a result, we don't have the cost-based reimbursement that critical access hospitals have, which allow them to flourish in rural cities. That means that we rely on the money coming in for the care we provide to balance out with our expenses to ensure that we can continue to thrive to support our communities. One of the ways that we've been supported in that is through a federal bill that allows an enhanced payment for low-volume adjusted hospitals. Unfortunately, this is another program that was not renewed and expired as of October 1st. This is another 1 to 3% reduction in our net revenues. All of these things stack together to hit us with a 3 to 9% reduction in overall revenues. Northfield Hospital and Clinic has been around for 100 years. We're not going anywhere. We're going to be around to serve the people in our communities, but this is making it harder and harder. 2 years ago, we lost $10 million. Last year, we lost $5 million. This year, we're shooting hard to break even, and that's been a real challenge as we've entered all of this uncertainty in the markets. One of the areas that we really have been focusing on is obstetrics. We heard from the individuals who live in our city and our region that access to labor and delivery and maternity care is incredibly important. As a result, we as an organization have gone against the trend of declining access to maternity care in rural settings, and we've invested in OBGYNs, invested in midwifery, invested in pre and post natal care. This has really been a positive thing for our community. We've seen our births increase year over year as others across our region close their birthing services. We see this continuing into the future because, as you've heard today, this is not just more of the same. This is a fundamental shift in how healthcare will be delivered in rural America. We are going to be experiencing that each and every day in the upcoming years. We anticipate that other community hospitals, as you just heard, are at greatest risk of closure. So while Northfield Hospital and Clinic is going to continue to serve our communities, the demand on us will grow into a larger and larger region, with patients traveling further and more frequently to get access to care at Northfield Hospital and Clinic. This means that we're going to need to partner with you and others across the state and in leadership positions to look at healthcare in rural settings totally differently. A lot of what we've been doing for the past decades isn't going to work anymore. I look at the example of OBGYN, obstetrical care. As other community hospitals close their labor and delivery units, and then they come to Northfield Hospital and Clinic, we now need to grow our labor and delivery clinics. This isn't possible due to moratoriums on inpatient beds in the state of Minnesota. We need to work creatively to think about what are new models of allowing reallocation of rural OB beds or rural access to care. Our emergency department is another area where we have a high volume of Medicaid patients and uninsured and charity care. We have an ambulance service that provides care, and we also provide excellent care in our EDs. The EDs are getting busier and busier with sicker and sicker patients. We're seeing this now. This is going to amplify in the future. This means our EDs are full, which means that our hospital beds are full, which means that patients will wait longer for care, and this will happen across the state as others in rural communities have to close their services. We need to prepare for this by expanding our EDs, expanding our access to care, and we need to partner across the state to understand how we can ensure that these essential services in communities are appropriately funded to make sure that they don't totally disappear, especially when you think about our community hospitals that are becoming rural community referral centers for larger and larger geographies. The last opportunity I'll highlight is that right now there is a lot of money in the Rural Health Transformation Program at the federal level. These dollars are going to be essential for hospitals like Northfield Hospital and Clinics. We need to make sure that we partner across our state to submit a proposal that gets the most of these federal dollars into our rural hospitals as possible. We're part of a clinically integrated network. As an independent, city-owned governmental hospital, Northfield Hospital and Clinic is able to be very responsive to our local community. We've partnered with 20 other rural hospitals across the state to come together into what's called the Headwaters Network. This group works to improve our care by sharing best practices and looking at clinical workflows, and also have more leveraging power when we try to get the best pricing when we buy products, and we partner with our insurance colleagues to make sure that care is provided to our communities. Headwaters Clinically Integrated Network has put forward great proposals to ensure that these $50 billion of Rural Health Transformation Program dollars make it to rural hospitals like Northfield Hospital and Clinic, and we're strongly supportive of making sure those dollars flow to the local communities. Thank you for the opportunity. I'd welcome any questions.
Thank you. I have a question for you. Based on the information that was provided by the testifier before you, between the cuts to Medicaid eligibility and the cuts to the ACA individual market, leading to more uninsured people needing care, they are estimating a total of $384 million a year in increased charity care costs, needs across the state. Can you talk to us about what an increase to that portion of what your hospital does would look like?
We're in the process right now of looking at our 2026 budget, and we're beginning to forecast exactly what you just described. And so we're looking at upwards to 10% total reduction in our net revenue. We break even at best, so that means we need to reduce our expenses by 10%. As we think about our expenses, the majority of expenses in a hospital and health system are staff cost and staff time. And so we're looking seriously at all the services we provide in our community. Northfield Hospital and Clinic is committed to providing those services, and so we're working hard to think about how to do it more efficiently, do a higher volume, make sure that we get the best pricing we can on supplies, but it's putting a lot of pressure on our bottom line. Our hospital is incredibly well supported by our community. So one thing we're doing is we're looking at our local businesses. We're looking at our local philanthropic community. We're looking at our local city to say, how can we partner with you to ensure that we keep these services in our community? Because we're not getting them at the federal or state level anymore, so we need to look to our colleagues across our local settings.
Thank you very much. We appreciate your testimony.
Thank you.
Members, finally, we will move to an assortment of voices from across our state representing small businesses, our seniors, and Minnesotans who rely on the individual market for their health insurance needs. Thomas Elness, if you would come up, and also Sean Fedeplace, if you can come up as well. Thomas, go ahead and introduce yourself for the record and present your testimony when you're ready.
Thank you, Chair Port. Good morning, subcommittee members. It is good to see each of you. Thanks for taking time to hear these stories and stats from Minnesotans. My name is Thomas Elness. I have the honor of serving as the Associate State Director of Advocacy with AARP Minnesota. AARP is a nonprofit, nonpartisan organization dedicated to empowering people to choose how they live. Thank you for the opportunity to bring the voices of older Minnesotans, including our nearly 620,000 AARP members statewide, to this critical discussion today. We've heard a lot of numbers today, so I'm hoping to share some stories with you as well. We appreciate this committee's willingness to understand the nuanced impacts of the new federal law on Minnesota in a bipartisan and facts-based way. And many older Minnesotans are sharing their concerns with us about health care. As you know, significant changes are coming to Minnesota because of new federal law, and I'd like to share two of them with you today. First, I'll start by discussing changes to the individual marketplace, often accessed through MNsure, followed by some of our concerns about changes to Minnesota's Medicaid program, known as medical assistance. So first, the changes to MNsure plans and premiums. Three key changes to the individual health insurance market are converging at the same time that will present a real challenge for Minnesotans. First, as you heard earlier, Minnesota Department of Commerce recently announced rate changes on the market ranging between around 7% and 27%. Second, new federal law imposes changes that will add even more red tape for enrollees, including new documentation and pre-enrollment eligibility verification. And third, unless Congress takes action, as you've heard many times today, the enhanced premium tax credits are set to expire on December 31st of this year. When all of these factors are combined at the same time, rising premiums, more red tape, loss of tax credits, many Minnesotans are at severe risk of losing their coverage. Out-of-pocket premium payments for people with these plans will increase an average of 75%, with older adults being hit especially hard, as you heard earlier. We are already seeing this take shape in Minnesota. For example, as Libby had shared earlier from MNsure, a 60-year-old couple earning $82,800 a year will see their annual premiums increase 167%, or just over $11,000 a year. We wanted to hear from our members on this, so we encouraged them to share their stories with us. We sent out a notice on Monday morning and have been so overwhelmed with responses that we can't get back to everyone. We've had about 100 responses in the first 24 hours, so people sharing their stories, and I want to share just a few of them with you today. Nate said his new premium price for 2026 has almost tripled compared to 25 and said, quote, "I will not be able to afford insurance in 2026 at the new rates." Linda said her premiums are doubling. If she didn't have to worry about these increased expenses, this is how she said she would spend those extra dollars. Quote, "I would be able to go out to lunch and take a few art classes and spend time with my family. I'd be able to get out and do things without worrying about how I can afford gasoline to drive to a free museum or do something social." You also have a letter from Tracy Fogelson from Byron, Minnesota, in the southeast part of the state. I had a chance to visit with her this week, and she shared her story with the committee in a letter. I hope you have a chance to read it. Tracy was able to treat the cancer that the doctors found in her body 13 years ago because of her health insurance, but that coverage went away in 2023. Tracy's husband worked with the same company for over 30 years, but was forced into an early retirement. Tracy's an independent contractor, and neither she or her husband are 65 yet and able to access Medicare. So today they rely on plans available through MNsure and the enhanced premium tax credit to be able to afford a health insurance plan. She worries that they will not be able to afford health insurance next year and got emotional, saying that will force her to forego ongoing cancer screenings and other critical care. It's not just our phones at AARP that are ringing. We learned this week that the Minnesota Aging Pathways, formerly known as Senior Linkage Line, saw a near doubling of calls over the past few weeks in response to disruptions in the healthcare market. I imagine your phones will start to ring on November 1st this year as well, if they haven't already, as some of the 78,000 working Minnesotans and their families relying on health insurance tax credits discovered during open enrollment that their health insurance premiums have substantially increased. AARP continues to advocate hard at the federal level to extend the premium tax credits, but if these tax credits expire, it will be especially difficult on the state of Minnesota when combined with the changes to Medicaid. These major forces happening simultaneously will drive up Minnesota's uninsured rate and be a challenge to the state's healthcare system, all things you've heard from others today. So that's MNsure. Second, changes are coming to Minnesota's Medicaid expansion population within medical assistance. Around 137,000 Minnesotans are eligible for medical assistance through Medicaid expansion, including 46,000 between ages 50 and 64. Because of the new federal law, these adults aged 19 to 64 in the Medicaid expansion population will be required to work at least 80 hours per month or fulfill similar criteria like participating in job training or community service starting January 1st of 2027. This creates a steep coverage cliff for those in their 50s and early 60s, particularly those nearing retirement or working part-time who may be left without affordable coverage options at all. So we encourage this body to keep in mind three things as you write laws and work with the state agencies and counties that are working to implement this new federal law. One, please recognize that caregiving is work. In fact, it's often one of the most difficult forms of work, and we must ensure that our family caregivers' tireless work counts toward the new work requirements. Second, realize that work alone is not enough to meet the new obligation. Work is only as good as the state and county and the insured person's ability to recognize that work and report it correctly. So we must ensure that the process of complying with the new work reporting requirements and that the bureaucratic process of seeking exemptions are easy to navigate. 3, please understand that finding work as an older adult can be more difficult. We know that age discrimination is one of the reasons it can be difficult for older adults to find work. As work requirements impact older Minnesotans in the Medicaid expansion population, and for the first time, those using SNAP, we may need more resources into programs like the Senior Community Service Employment Program, which helps people age 55 and older find part-time work. In addition to work requirements, federal law now requires states to perform twice as many redeterminations in Medicaid for expansion-eligible adults, shifting from 12 months to 6 months for renewals. This body, as well as, again, the state agencies, and in Minnesota's case, the counties that are implementing these changes, should do everything it can to, 1, ensure options for those without computers and broadband. 24%, a quarter about, of those on medical assistance only have a smartphone or tablet, and another 13% do not have a laptop, desktop, smartphone, or tablet at all. We know that this can disproportionately impact older Minnesotans. In fact, Minnesota recently had the 3rd largest gap in access to broadband between younger and older adults, but we are making some improvement. 2, please ensure that processes for redetermination limit bureaucratic blunders. No one wants a bureaucratic process to be the reason somebody doesn't get the health insurance that they deserve under the law. So, for example, we should aim to use existing state data to confirm eligibility whenever possible. So ultimately, our ask of you is to please get this process right. We encourage you not to rush the implementation of these new requirements and ensure sufficient resources for the administration of these new requirements to minimize enrollees slipping through the cracks. We already have work to do in Minnesota on our call wait times, our call abandonment rates, procedural disenrollments, and these changes will exasperate these issues. And we must find solutions at the state and county level to be able to implement new federal law. The effects of this new federal law will be felt narrowly, both by those directly directly and broadly, as the state grapples with rising uninsured rates, new mandates, and budget challenges. The way that the new federal law is structured, funding reductions coming to the state of Minnesota will take place over many years. This body, more often than not, has chosen to support older adults in need through home and community-based services and other critical resources, and we sincerely thank you for those investments. As you navigate changes to the state budget, please do all that you can to maintain Minnesota's ethos of caring for one another and investing in the services that help our older adults. Thank you for the opportunity to speak today.
Thank you, Mr. Elness. Mr. Fediplace, if you want to introduce yourself, present your testimony, and to let our 2 testifiers on Zoom know you'll be up next.
Cool. Thank you so much. Is this close enough? You hear me? All right, cool. Thank you, Chair Port. Thank you to the members of the subcommittee. My name is Sean Fediplace, and I'm the National Campaigns Director for the Main Street Alliance. And we represent about 30,000 small business owners across the country and about 1,600 here in the great state of Minnesota. Our members include restaurant owners, childcare centers, manufacturers, runs the gambit. We have a member who's going to be testifying here in a moment who owns a brewery, which I know is a popular type of business in this state. And we often represent sole proprietors, people who are, running consulting businesses, people who have teacher businesses that they're doing everything on their own. And those folks, if you look at recent studies, over 50% of the people in the marketplace are small business owners, they're staff, or they're folks who are sole proprietors themselves. And so they're especially impacted by these cuts. There's also been a general trend of increasing costs over the course of the last couple of years, whether that's food, other products as a result of tariffs or other increasing costs, and the increasing cost of healthcare is making that even worse. We surveyed our members across the country, and about 44% of Main Street Alliance members indicated that they would either have to stop hiring, that they would have to make modifications to their benefits, and most of our members are under the 50 staff threshold that requires group coverage. And many folks are in the marketplace themselves, but many of their staff are as well. Healthcare's been an issue for a very long time in general for small business. I do think it's really important to understand that because of the Inflation Reduction Act and steps during the pandemic, the amount of enrollees in the marketplace went from 11 million to 22 million. It literally doubled, and that was a result of largely fixing problems within the marketplace in terms of affordability more broadly. So even though it happened during the pandemic, it was a result of addressing a need, a structural problem within the marketplace that should have been dealt with years ago. Katie Rose is an example of a member of ours. She's a James Beard semifinalist, and pretty extreme example. She actually received a cancellation letter from her insurance company, and then 2 days later was diagnosed with cancer. She thankfully has coverage right now, but she's not sure if she's going to be able to afford it once the changes go through. You also have a member in Duluth who was quoted saying, if premiums go up again, I may just lose my insurance, I might lose my business. My customers are cutting back because of rising costs. And it's really important, I think a few folks brought this up earlier, to understand that this is impacting both rural areas, much worse, but also that older adult cohort. I think that's being lost in a lot of the debate around this, is that 55 to 65-year-old threshold. So a married couple making $80,000 a year combined, so that's $40K each, which is below the national average, their premiums will go up by $18,000 a year. They're just not going to be able to afford that, so they're just going to drop coverage. And it's going to be very hard to find a job that provides coverage because of age discrimination at that point in their lives. So this is going to create massive issues within the insurance market if it's not undone. Furthermore, as far as entrepreneurship goes, you have folks that are in childcare. Many of them are in the marketplace. Many of them are in Medicaid. And if they are not able to get coverage that way, they're just going to leave the industry. That's going to create workforce issues as well across the state. So for us as an organization, we're working really hard to represent our members to push back against these cuts, both federally. Right now, we're working very closely with Congress to make sure they get this undone. But I'll be honest with you, I'm not optimistic that the GOP is going to come to the table on it. I hope they come and negotiate. In the end, small business owners need a healthy marketplace. They need these subsidies. It is absolutely necessary to make sure that they can remain covered. And if that doesn't happen, then we're going to have a lot fewer small business owners in the weeks and months to come. And with that, happy to answer any questions you might have.
Thank you very much, Mr. Fetterplace. We'll turn to our two testifiers on Zoom. And while they are testifying, if we could have Casey Gordon, Laura Cresson, and Alina Hortfelt come to the table, please. Laura Myers, we'll start with you. Go ahead and unmute and introduce yourself for the record whenever you're ready.
Hi, everyone. Thanks so much for having me. I'm Laura Myers, proud Main Street Alliance member. I own and operate a really small production brewery in Northfield, Minnesota. We're really small. We're very taproom focused. I'm here in our tap room right now, so welcome to my office. Yeah, we have about 15 employees, like really wonderful humans that I get to work with every day. Really love my job, but it's also extremely hard already. And thinking about the potential cuts and kind of just everything that's going on right now is really heartbreaking to hear a lot of these stories. And I'm really concerned about how this is. There's three things that I'm most concerned about. The first thing is these wonderful employees that many of whom I've worked with literally since we opened our doors. I have two full-time folks that I work with, and luckily one of them is married to a teacher, so he is able to get health care through his spouse. And then my other full-time person, he works at a small business, and we're so small that we're not able to provide health care. And we just can't be competitive in that way. So that's already a hardship for us. His partner also works at a very small business that doesn't provide health care. So they are in the marketplace. They have a young family and are actually growing that family come February. And we just are, kind of trying to do the estimates and figure out what are the things that he's going to be looking at? And for his family, they're looking at potentially an increase of $3,500 per year for their health care next year. And, like, I really love my people. Like I said, I've worked with them for a long time. They're like my family, and I mean that in a really good way. And so thinking about, like, how can I support them? I try to pay really fair wages. I try to do the best I can, but we're already struggling, so I can't necessarily promise to help compensate for that gap. So then what do we do? Do I lose that employee? I really hope not, because he's invaluable to my team. I also have a number of part-time folks who, some of whom are in the marketplace or are thinking about needing to make that move. I have a retiree who is hoping that he's going to be able to continue to have health care. He's had some recent cancer scares. Luckily, his wife is still working, and he's able to get healthcare currently through her. But as they age and are hearing about all these cuts happening everywhere, it's really scary for them, and we've talked about that. I have a lot of young folks who are also navigating all of the difficulties of a weird job market and paying off their student loans and working here part-time while they're also working a second job or trying to get their careers going. So that's what keeps me up at night, is how do I take care of my people who desperately need to be able to take care of themselves and their families. The second thing is my community. Like, we're really community focused. We are, like the old public house. We want to be a community gathering space. And so I always tell people, like, yes, we love beer. We love making beer and selling beer. That's what we do. But it's really not just about the beer. It's about the people. It's about people coming together. And already this year, we're seeing a lot of our customers are tightening their purse strings. They're seeing the writing on the wall. This economy isn't feeling good. Oh my God, now all healthcare costs are going up. All these other costs are going up. So when those necessities cost more, they're not going to come and spend money on a craft beverage that's going to, cost them a little bit more. Even if they love to be here and want to support us, they can't. And it breaks my heart for the community, for my community members. For example, today, I don't know if you can see, like, behind me, there's our brew house back there. My colleagues are hard at work. And they're brewing a beer, actually, that's going to be a collaboration with our local organization, Laura Baker Services Association. And so we're making a beer that's going to, like, some of the proceeds from this beer will go to this organization that helps folks with disabilities. That kind of thing is so critical to, I wouldn't do this job if I didn't get to do those things. And I'm thinking about what are the effects of my community when folks are going to be struggling to just get their health care right. And that's one example. I know there's been a lot of challenges for families with folks with disabilities and their families. So that's really present in my mind today. Not to mention the fact that if people can't afford to come here, then I don't have a business anymore. And then I'll just personally, I'm also in the marketplace. My husband works for a very small nonprofit as a side job, as well as working here part-time. So we are in the marketplace looking for our health care and looking like we're going to be spending an extra $2,000 next year based on the estimates we're seeing. Which probably is fairly manageable for us, except that the first thing that's going to get a cut if this business is struggling is my salary. So we've done everything. We learned a lot during the pandemic, and we have cut expenses, and we've figured out how to, like, hunker down and make this work. And there's, like, only so much we can do, especially as we see rising costs of everything else and potential for tariffs, especially on all that stuff that you already know about that's related to the beer world. So if my salary gets cut and we're seeing those rising healthcare costs personally, that's just another struggle on top of the whole thing. So I love talking about beer. I love talking about our community. If any of you ever wants to come and visit with me, I'd love to buy you a beer if I can. I don't know if I'm allowed to do that. Yeah, just I know that we can do better to make healthcare not only more affordable, but just better and easier for folks to navigate. The number of stories that I hear from my community members and my fellow small business owners is just, it's really frustrating. I know we can do better, and so counting on y'all to help make that happen. So thanks so much for the opportunity to come and speak today. Really appreciate it.
Thank you very much, Ms. Myers. We appreciate you sharing your story. Next, we'll go to Carol Colseth online, and just a reminder for our testifiers to try to keep it at around 3 minutes. Ms. Colseth, thank you. Please introduce yourself for the record and then present your testimony.
Good morning. My name is Carol Colseth, and I'm the Secretary Treasurer for the Pennington County Farmers Union. I live 10 miles south of Thief River Falls, Minnesota, and I'm glad to be able to share my story about the impact of increasing insurance costs, particularly for families like mine. And thank you for letting me testify remotely since I live a long way from St. Paul. My husband and I are full-time farmers. Our farm has been in my husband's family since 1914. My husband Dale started farming right out of high school in 1983, and I started with him when we got married in 1992. And it's been a very good way of life for us, and we're motivated to make that opportunity a reality for the next generation. We're proud that our daughter and son-in-law are now in their second year of farming with us. And we also have one full-time employee, and we farm together 3,100 acres approximately, and about half of that is rented land. We raise wheat, soybeans, and hay, and we do not have any livestock, so everything that we market, we have to market everything we produce. And healthcare has always been a challenge for us. When we were first married, I worked full-time off the farm, and that's how we got our health insurance. But I would work at my full-time job all day and then come home to a note on the table telling me what field to go to, and I'd work in the field till about 9 or 10 p.m. And so shortly before our daughter was born, I quit my job and to work full-time farming. And for many years, when we were in our 30s, we went without health insurance. And farming can be a dangerous occupation, and we knew we were taking a risk, but it would have been a big piece of our budget as we worked back then to build our farm by buying land and machinery. And then during the first trade war and through the COVID pandemic, our incomes were low enough that we qualified for coverage through Minnesota Care, and we were very glad to have that coverage. But then last year, our income was high enough that we were no longer eligible for Minnesota Care. And I got a notice a year ago that we would lose our coverage through Minnesota Care at the end of October. And so my husband and I went to have our annual physicals while we still had insurance. And at the time, all I was worried about was that my cholesterol might be a little high. Well, my cholesterol was fine, but I needed to have a second mammogram. And that second mammogram was on October 29th. And then they told me I should have a biopsy in Fargo because that mammogram was abnormal. And so then I just had 2 days to find health insurance coverage. And I did find a plan through Blue Cross Blue Shield, a silver plan on the individual marketplace. And I ended up having a double mastectomy in Grand Forks, North Dakota. The procedure cost close to $45,000, but because we had insurance, my out-of-pocket was just under $9,000. And if I didn't have insurance, I might not have caught my cancer until it had gotten much worse. And paying for more advanced treatment out of pocket would have been a big challenge for our farm. Right now, our premiums are $1,603 per month, and we're finding a way to make that work. Just yesterday in the mail, I got a letter from Blue Cross Blue Shield that our premiums will increase to $1,972 a month, which is a 23% increase. So we will pay $4,428 more each year. And I did look at the MNsure website, and I found some plans on there, but they were still $1,720 a month or $1,873 a month for a plan similar to what I have. And we're trying to figure this out. We're established on our farm, and we're looking at other places we can cut expenses to make this work, because at our ages, I'm 53 and my husband is 60, we don't want to be without insurance. But what I worry about is younger beginning farmers that may have those high land payments and operating loans. And I know that our daughter and son-in-law, they work full-time right now and have insurance through their employers. And I know they would not be able to afford to come to work full-time on the farm because they couldn't afford health insurance. And for young people, these high health insurance costs just discourages them from getting into agriculture or starting small businesses. And I think that's going to be a big loss for our rural communities. And it's also tough on small employers. We have one full-time employee. He's been with us since 2017. And we're very lucky that his wife works for a big regional employer and she gets her insurance through there. And if something ever happened where she lost her job or couldn't work, we wouldn't be able to provide insurance for him and his 4 kids. And he wouldn't be able to afford to buy insurance on his own. And finally, I'll just share that this is also coming at a terrible time for the farm economy. The grain markets are at multi-year lows, largely due to the trade war with China. And in our case, the majority of our crop from this year is in storage. We're waiting and hoping that the prices get better. And also the input costs right now are as high as they've ever been. And I'm hoping we'll figure this out, but I think it was important for me to testify today because not every farm family will. And I think some will probably be pushed off of their insurance or they'll be pushed out of farming. And that's not good for those families, and it's definitely not good for the rural communities. Thank you.
Thank you very much, Ms. Colseth. Casey Gordon, if you would introduce yourself and present your testimony.
Yes, thank you, Madam Chair Port and Senators. My name is Casey Gordon. I am a grant writer for education and food security, and I'm here today to tell you a little bit about my healthcare journey, and I hope that you see it as a success story for what can happen when you invest in people, and I thank you for investing in me over the years. I spent my 20s and 30s working at a public university as an adjunct instructor and working part-time jobs to supplement my income. And I did not have steady insurance during my 20s and 30s. And in 2019, my brother was diagnosed with a grade 4 glioblastoma here in Minnesota. And I moved back from New York City to support my family. And at that time, I left a well-paying job that I had finally established in order to move here and get a part-time job for $15 an hour. I lived with my mother and my sister in a 2-bedroom apartment and was able to get on the ACA insurance, a Minnesota marketplace, and pay nothing for my insurance because I qualified. I was able then, from 2019 up until this year, to slowly utilize programs to establish care with amazing PCPs and to learn the healthcare system that I never got to learn and to utilize that healthcare. I was able to pay off my student loans and get support from the government to pay off my student loans, which I know is potentially controversial, but I want to tell you that with that extra funds, I was able to start investing in my own retirement fund. I was able to start saving for a down payment for a home and participate in the marketplace. I was very honored to be able to do so. And I fixed my credit and I was able to really establish myself as a Minnesotan in the community. I started working as a grant writer, and on August 28th of this year, I was diagnosed with an aggressive form of breast cancer. I am coming off of chemotherapy yesterday, so I'm sweating chemotherapy right now. And from August 28th up until October 14th, yesterday, I spent all of my time figuring out my care. I have a wonderful care team at Regions Hospital, and Yesterday, I met with a social worker for the first time. And from now until the end of the year, I have a quick list that I will read you of all of the appointments that I am going to have to try and figure out what is the right thing for my family. So right now, I have a non-traditional family. I have a brother who is still alive against all odds. He was given 9 months to live. He is still alive 7 years now, but he is disabled. He cannot work. And so I have a family structure where me, my mother, who is retired and working or living on Social Security, and my sister and my sister-in-law provide all the income for our family. And so when I was diagnosed and realized that I was going to have to navigate something new and scary and very big for me to understand, I have to take into account all of my family members. So from October 14th until January 1st, when I can finally figure out what is the right plan for me, I'm very fortunate that I can afford care, and I will have to take money from other places in order to afford care. I can't afford to not pay for it. So I will have meetings with social workers. I will have a meeting with the Angel Foundation for financial planning. I will have meeting with other grant writers to do grant applications for deductible support because I had to purchase a high deductible plan at the beginning of this year. I'm talking with an HR representative from my job. Right now, I am an independent contractor, so I do not get health insurance from my job. I will be talking to an HR rep. I work for a national organization. They have insurance in California. I'm gonna then have to take those plans that they present to me. I'm very fortunate that they have offered that to me. They're a wonderful organization. And I'm gonna have to take those plans plus all the ACA plans and have a meeting with a broker from the marketplace who can help me figure out what the payments will be. I am going to have to get my mother on SNAP benefits. I right now support my mother with her groceries. So we're looking at SNAP benefits. My mother has also been kicked off her supplemental Medicare insurance with UCare. I found that out yesterday. I don't know much about it. We just were talking about it in passing. So that's something I'm thinking about. I have a therapist who has gotten me through the last 6 years. It's taken me a long time to find that therapist. At the beginning of this year, that therapist changed jobs and I lost insurance through them. So I have to talk to my therapist to see if they're covered. I have to figure out if my cancer is covered. Right now, if you've seen commercials for Keytruda at nighttime, I am on Keytruda. That drug costs $60,000. I just found that out. I'm on my app all the time. That drug takes me from a 51% chance of a complete pathological response. That means 51% chance that the chemotherapy will get rid of my tumor to a 65% chance. I am terrified that even when I find my insurance, and if I find that it covers it, will they deny that drug? That is an experimental drug that's been out since 2020. I just have 2 more pages. I'll be fast. I have to contact my own financial planner at Edward Jones to say I have to stop my retirement contributions and I have to stop my down payment on my house contributions. Those dreams are on hold. Those dreams that were made possible by the ACA, by Public Student Loan Forgiveness Act. And in December, when I start a chemotherapy treatment called the Red Devil, and I don't say that for fear-mongering, it's because the real name is very hard to remember. When I start a chemo treatment called the Red Devil, which will make me have to go in for heart monitoring, go in and make sure, because it's very intense, it's derived from mustard gas, that's when I will have to make the choice what insurance I have and whether or not I will be able to continue working, and if there are subsidies for me, if that chemotherapy is too hard for me to take and I have to stop working. So those are all culminating in the next 3 months. Having cancer is a full-time job. I'm fortunate to be working part-time, and I'm really grateful to you all for listening. Thank you.
Thank you very much, Ms. Gordon. Ms. Crescent, if you would state your name for the record and present your testimony.
Thank you, Madam Chair, and thank you to the committee. My name is Laura Crescent, they, them, and I am a freelance web developer from St. Paul, Minnesota. Over the course of 7 years as a freelancer, there have been some years where my income was low enough that I qualified for Minnesota Care. The low costs and fees gave me really great peace of mind, especially during the pandemic when my work was inconsistent and my health was poor. In the last couple of years, my income has reached a level where I no longer qualify for Minnesota Care, so I had to rejoin the individual market. This year, I pay a $330 premium for an $8,000 deductible plan. Between my premiums and my out-of-pocket costs, about 20% of my income after taxes goes towards my health care. I can't really afford my health care as it is. After the passing of the federal budget bill this summer that did not extend subsidies for individual plans, I'm looking at about a 12 to 16% premium increase. I'm going to have to make some very difficult decisions about my health care this next year. Which of my preferred clinics I'll be able to have covered, what appointments I'll still be able to go to, how often I'll be able to go to those appointments, and what risks I'll have to be willing to make when I have to sign up for a more affordable plan, probably with less coverage. If I get a head injury like I did in 2020, will I be able to afford to go to the emergency room to get an MRI? Or if I get bronchitis like I did this last spring, will I be able to afford to visit the clinic if I have a dangerously high fever? The cost of my medical care has already stood in the way of my financial goals. I can't afford to buy a house, start a family, or save for retirement. But I always told myself that my health was more important. Healthcare has helped me maintain a better quality of life and allows me to do the things that I want to do. I can be a better family member, friend, web developer, and community member when I get the care that I need. Now, with the ending of these subsidies, not only will I not be able to work towards my other financial goals, but I won't be able to afford to maintain my health either. I encourage Republican and Democratic legislators to join together to help Minnesotans like me afford health care. Health care saves lives. Health care has saved my life. And it's something that no Minnesotan should have to go without. Thank you.
Thank you very much, Ms. Crescent. And our last testifier, Alina Hortfeld, please introduce yourself for the record and present your testimony.
Thank you, Madam Chair and members. My name is Alina Hornfeld, and in 2023, my best friend and I became co-owners of Mastel's Health Foods on St. Clair Avenue here in St. Paul. As you can tell from the name of our business, focusing on health and people's well-being is core to me and my livelihood. And not surprisingly, I have a lot of concerns about the GOP cuts to Medicaid and the refusal to extend the tax credits that make healthcare coverage affordable through the exchange and how it's raising costs for all of us, no matter how we get our insurance. Our small business isn't able to provide health insurance for any of our employees, so my family gets our insurance through MNsure. The plan we had this year, despite costing over $1,000 a month, already has extremely high deductibles, high copays, and doesn't cover some preventative care that should be standard. And now the premiums are going to rise an average of 20%. This will force hard choices like switching to a plan that covers even less or going without insurance altogether and gambling that we don't get sick or have an accident that could bankrupt us. This is certainly not the way to support entrepreneurs and small business owners. The cuts also impact my staff, who pretty much all buy their health care on the exchange and most qualify for the premium tax credit. I know one who already limits her hours and has turned down promotions because she can't afford to make more and lose the affordable health insurance policy that she currently qualifies for. If costs rise and coverage gets worse, I could see her and other staff leaving to find a job that can provide benefits. Even if they love working at Mastel's, would we even be able to find staff that could replace them? Finally, as premiums spike and prices for everything from food to housing becomes even more unaffordable, we know our customers will start tightening up their wallets everywhere. We have some folks who will prioritize their supplements over a lot of things, but many people will choose to go without, which will absolutely hurt our bottom line. We would need to figure out where and how to cut back, which isn't easy with a small shop like ours. These cuts are bad for our community's health and bad for businesses.
Thank you very much for your testimony. I'm going to go right to Senator Nelson because I know you have to leave. If you have any closing comments.
Okay. Thank you, Madam Chair. And members and the public, I just thank you for this discussion today and for all that were able and willing to share their own personal journeys with healthcare or the lack thereof or the unaffordability of it. I appreciate all those comments. For my fellow breast cancer survivors, I'm very thankful we live today when we have the treatments and care that we have today. But the reality is the healthcare issue, healthcare in general, is such a complex issue, and I see we've taken that in some way today, and I think everybody truly understands that. And I want to be clear, though, if we are very serious about getting these healthcare costs under control and still having the excellent healthcare that is saving our lives today, we do have to look at everything. We have to look at everything that has led us to the point where we are today, where we're seeing the high cost of healthcare, and then how do we pay for it? And the reality is, again, that yes, those federal discussions are happening right now. And we have to also look at what has happened in Minnesota. Where do we have control? And what has happened in Minnesota healthcare? And what we do know, we can look back and we can see that in 2010, when the Affordable Care Act passed, or nicknamed Obamacare, we were told that it would be a transformational fix and that we would see lower premiums for families and businesses. But that is not what we have seen. It did not solve our healthcare crisis as many had hoped. And so here we are today. We had good, bold promises, but they just did not turn out very well. And so here's what we had in Minnesota prior to the Affordable Care Act. We had something called Cmte, and that was really working pretty well. But because of the new federal program, we had to scrap Cmte. That was our high-risk pool. And until we passed reinsurance, and I'm very thankful for the passage of reinsurance, we know that the individual market, which would have impacted all of our small business employers particularly, was literally on the brink of collapse. I know some of you weren't here then, but some of you were, and you remember the challenges of getting that reinsurance passed. And so I'm very glad to say that we did once again have repassed reinsurance to help. It's not a total solution, but it helped. But the sad fact, the reality is that we're here right now because these issues of exploding healthcare costs have been building for years, and they've been years in the making. And so some want to take, and we want to point our fingers at Washington, D.C., and while we don't have that control there, and we can talk about that later, but what can we do right here? The truth is that right here in our state, in the state of Minnesota, in 2005, when we had an $18 billion surplus, it was not health care and making health care affordable through support was not prioritized. That's challenging. $18 billion surplus, and actually it turned into a $6 billion deficit as state government grew by 40%. And of course, we don't like to hear this. I don't like to hear this. I'm tired of hearing this. But in Minnesota, our fraud has been running rampant. We've had over $1 billion already documented, some looking at 2, some thinking it might be up to $6 billion. And I just want you to think about, what if we'd been able to invest those dollars in actually helping Minnesotans? I think that is something that has been a concern for all of us. And so I want us to focus on those things that we can control right here in Minnesota. You know, we don't have a magic lever about what's happening out in D.C. And that has been, I think, where I would hope that we will focus next year going forward into what can we do in our state to help make health care more affordable. And I would add just a couple things. I know we're all disappointed. We've heard a lot of finger pointing today. And the federal shutdown, I agree, it's been a problem. And it's going to continue to be costly to Minnesotans, very costly. And we're already feeling it. Some of you have already mentioned it. I know we've seen that already. And I am really hopeful that they can figure out an agreement soon. We are all waiting for the federal government to figure out the agreement so that they can open up the federal government. And the blame game, I know, I've heard that here. We hear it everywhere, I think. And it makes good social media clips for sure. But it doesn't really help those of us who are being stressed. It doesn't really help our families. And the bottom line is the thing that matters are facts. And that's where hopefully this hearing can be helpful in getting some of those facts out there, making sure that we hear and are aware of how this is affecting Minnesotans. The shutdown has been problematic. It's going to continue to get worse. And I worry about that. And the facts are these, folks. The U.S. House did pass that clean continuing resolution like they had 13 times before to avoid a shutdown. But you all know how government works there. It has to also pass the other chamber, the Senate. And the Senate did try to pass that clean resolution multiple times. But the thing that I don't think I've heard, which I think is important to know when we're talking about facts, is it takes 60 votes to end a filibuster. And that's why it hasn't passed the Senate yet. There have not been 60 votes to pass that clean continuing resolution. There's actually only 53 Republicans, so there needs to be a few Democrats to help as well. So far, unfortunately, they've refused, and unfortunately, both our Minnesota U.S. senators have continued to vote to keep the shutdown going. I'm just hoping they all change their minds. We get the government open. We should be discussing, we should be getting our government open and talking about what's going to happen here at the end of the year. What is going to happen with those enhanced premium tax credits? I know there are people who think they should continue. I'd like to hear that as well. And so we need to have the discussion. And so my hope is that as we go forward, that we will be able to get the federal government to do its job. But here in Minnesota, we have to make sure that we do our job. And I referenced this earlier in my comments, but I want to make sure the numbers are clear. There are things that Minnesota did to make health care more expensive. For example, in 2025, $549 million of new taxes onto our managed care organizations. $594 million of new taxes. How do you think they get their money? They get it through the cost incurred. They don't have a printing press that makes those $594 million. So that is just an additional cost onto, in this case, our health care. And then there was over $30 million of additional taxes on health care facility fees. Why do you think our health care costs are getting so high? Part of it is what we're doing right here in the state of Minnesota, increasing those fees by over $30 million. They have one place to get those fees. It's from the patients. It's from the increased costs. We have to realize that when the legislature passes these kind of things. In 2025, this legislature also passed $54 million of increased taxes on prescription drugs. What does that do to the cost of prescription drugs? It just makes those more expensive. And I think we have to realize that we cannot do those things and think that we're going to make our world-leading health care affordable for Minnesotans when we keep passing nearly $1 billion of new taxes onto our health care facilities and our providers and our wonderful new prescription drugs that are providing great relief. So I'm hopeful going forward, Madam Chair. I'm thankful for the hearing today and for all those who have come and shared their concerns. I agree. I hope that federal government gets their act together, opens up those, gets that continuing resolution out of the Senate, and then works on these enhanced affordable care tax credits. I happen to think they're important. So thank you, Madam Chair.
Senator Marty.
Thank you, Madam Chair, and thanks to all the witnesses who testified today. I gotta say, I'm very scared for our Minnesota neighbors. I think the Hospital Association estimated 60,000 who dropped their coverage because of the loss of the federal advanced premium tax credits, another 140,000 from the HR 1 losing their Medicaid coverage, 200,000 people. Every one of you who are struggling to figure out your health care, every one of you is making those difficult choices, and it's a real painful choice for those 200,000 people who say, I just can't do it anymore. That may be in some people's minds fine if they're able to, if they're in good health right now and they don't need to go to the doctor now. It's not a problem until they need. But again, some of you who are dealing with cancer, the farmer up in Thief River Falls, and you and others, you don't have that choice. And so I very much fear for those who make that painful decision to have to drop coverage or pick a plan that's even worse. When you said an $8,000 deductible, that's not health care. It's a catastrophic coverage, perhaps. But related to all that is what the Hospital Association and others were talking about too. It's not just the people losing the coverage in there, but it's the stress on the entire healthcare system. And the risks for the hospitals, the clinics, the providers who can't continue serving. And again, in some communities, it's going to be even further drives for people to get there, which puts more burden on everyone. And I keep thinking, we keep talking, we got the best healthcare system in the world. No, we got the best providers and best doctors and nurses and clinics and hospitals and medical technology and so on. But the worst way of getting care, when in a first world country, you have to drive 2.5, 3 hours if you live in the Arrowhead to get to the nearest hospital for childbirths. So we're in a bad shape already, and now these impacts at the federal level, both the biggest one is obviously the Medicaid cuts, but also the tax credits. And I understand why some people are saying we're not willing to sign off on anything until you're going to bring back those tax credits, because these few weeks are when people start buying their policies, and I think you're all seeing that and you're scared of that. And the thing that bothers me, that is in the same way it hits the individuals involved, not just 200,000 who are losing coverage, but everybody who's on the verge of it, hurting them too, and how that has the ripple effect on the whole healthcare system and everybody else, because everybody else is going to either, if they lose a hospital, they're all suffering. But this is all on top of the other stuff, the SNAP cuts and so on. And again, that hits directly some of the very same people here. And again, that impact has the same impact on the system we have around that. All the food shelves and food banks, everybody we had testify a couple weeks ago, they're saying they provide 1 meal for every meal every 9 meals SNAP provides. So SNAP is so urgent, and it's going to put more burden on that whole community. So all those providers, all the healthcare providers, everybody else, it seems to me that we're intentionally inflicting upon ourselves as a nation a crisis in our economy and hitting most vulnerable people hardest. And so I'm very scared for that, and I hope we find a way to deal with this. But Madam Chair, I appreciate your taking the time to schedule this hearing.
Thank you, Senator Marty. Senator Mann.
Thank you, Madam Chair. I think the takeaway for me today was that 20,000 Minnesotans will lose their health care, plain and simple. Hospitals are going to pick up the tab, wait times are going to increase, hospitals were closed, people will have to choose between their health and food or rent. We could have cut tax credits that go to billionaires with that federal bill, but instead we have a federal government that cut health care to working people. That was a choice. That was a very, very deliberate choice. And I've heard no one today, not one single person, come up here and say, yes, when we make sure that people don't have health care, things get better. Not once. And the same thing last week. Not one time did I hear someone say, when we make sure people starve, things get better. Not one time. So this bill, again, coming from the federal government, very, very deliberate choice. Then I heard the comment that there's a bipartisan effort to extend the tax credits. And if that were true, we would not be sitting here today. We would not be sitting here having this conversation. We would not be in a government shutdown over these tax credits if it was a bipartisan issue. Republicans literally shut down the government because they did not want to extend these tax credits to everyday people. Instead, they wanted to extend tax credits to billionaires, to their buddies, to their friends, so that they wouldn't lose their tax credits. And then I heard, well, let's blame the ACA for this. That's fantastic. But we're not sitting here. It's not because of the ACA that 200,000 Minnesotans are going to lose their health care coverage. It's because of the federal bill. And let's put a pin on the fact that prior to the ACA, the individual market was not subsidized. The ACA made health care more affordable in that market, increasing health care access to 20 million Americans, and providing the lowest uninsured rate in the state of Minnesota in history. And of course, it actually covered services, right? We heard maternity care, we heard pediatric care, we heard prescription drugs, which were not covered prior to the ACA. So, then let's shift to fraud. Let's blame fraud for this. Okay, so clearly taking away the health care for 20 million Americans is the answer to fraud. It is not going after the large corporation and businesses who commit this fraud. It is removing health care from the people who use it. I mean, come on. So the reality is that we are sitting here now today because we have a federal government that is completely out of touch with everyday Americans. And it's not about pointing fingers. It is about putting accountability where it belongs. And it's very, very rich to say that we shouldn't point fingers and then blame the minority party for a government shutdown and for the loss of health care when Republicans run the entire government. Okay, I'm gonna calm down. So yes, healthcare is very complex. We do have to look at everything, but today we are looking at the federal bill that will fundamentally change the healthcare in this country for the worse. And I say this every time, but we have to be louder today than we have ever been because we are going down a very dangerous road. People are going to die because of this, and we have to do something, and it has to be urgent. Thank you.
Thank you, Senator Mann. You know, I will say when I agreed to chair this committee that I didn't think I would be on the verge of tears as many times as I have been, and we're only like 4 weeks in. But this is a time when many Minnesotans are struggling just to afford the basics: housing, food, childcare. And for many of them, shopping this week, health insurance. 2 weeks ago, we talked about SNAP benefits and food insecurity and the new strains and burdens that were put on that program. And yesterday, we learned that SNAP benefits will end November 1st if the government is not reopened. And today is the first day that no new approvals will happen until the government is reopened. So as people are thinking about increased costs, they're also not going to have food assistance. Starting today. I am struck today by the fact that we are talking about higher prices for consumers, higher costs and less resources for our hospital systems, less reimbursement and more paperwork for our counties, all to provide less care to fewer people. We cannot go back to a time of a high-risk pool for people who have pre-existing conditions, to women paying more for health insurance just because you're a woman, to uncovered maternity care. The ACA did not exist when I had my first baby, and it was very expensive, like $13,000 just to have a baby, out of pocket, because that care wasn't covered. We can't go back to that. There is a better vision. We have to do more. And to do that, we have to put people and actual access to care in the center of the argument, not profits at profit margins for insurance companies that can deny care, or putting more barriers between people and care. That's not the answer. A better vision is possible, but right now, what we are seeing at the federal level is barriers and burdens instead of visions. The decisions we make as elected officials matter. They matter. And the Trump trifecta in Congress gave tax cuts to the richest Americans, $1 trillion to the top 1% of wealth. A third of that amount, 1/3, would have renewed the enhanced income tax credits for a decade. And now we're watching as House Speaker Mike Johnson won't even call the House to order, negotiate with Democrats, or swear in a duly elected member. Over the course of the next 2 weeks, this committee will turn our attention to the government shutdown and the burdens and the costs that it is placing on Minnesotans. But I think it is clear today that what's happening in Washington, what the Trump trifecta is choosing to do, is not what the people of Minnesota, what the hospital systems of Minnesota, what regular people who just want to get their health care, it's not what those people are asking for or what they need. We have to do better. Members, I hope that we all learned from our testifiers today. I know I did, and from our roundtable in Northfield last week. Thank you all for joining us again. I look forward to seeing you soon. We are adjourned. Restrictions, more paperwork, higher costs in order to get less care. And that is going to affect people all across the state of Minnesota. We're looking at 60,000 Minnesotans losing healthcare coverage just because of the increased premium, the loss of those tax credits. That is a huge burden for those families, for those individuals, and also for the hospital systems all around our state.
It seems like a lot of the conversation today was about those premiums. That's been at the center of this government shutdown, situation as well. Before we get to that, do you guys want to talk a little bit about the other aspects of federal impacts that we heard about today?
Yeah, do you want to?
I'll make one brief. The trouble is they all multiply. Yeah. The SNAP cuts, the loss of the Medicaid, that's huge. That dwarfs this. But right now, at this point where the advanced premium tax credits are on the table, that's why we have to fight so hard to change that right now. But all these things multiply. All these things not just affect the people who get the care, it affects all the infrastructure behind it, all the hospitals. You shut down a hospital, it affects everybody. You make a hospital go underwater and have to shut down their maternity care, it affects everybody. And these sort of things, we're taking a system that's been struggling in the past, we're taking people who are struggling with cost of living, making it much worse. And that's not what the people want. I don't think anybody should be wanting that for our society.
The shutdown obviously is the biggest federal issue right now. You mentioned that you guys are going to be covering that next week. What can we expect to hear about?
Yeah, we'll be talking hopefully with some federal workers who have lost their jobs, though that's folks are feeling challenged about speaking out about that. Looking at the day-to-day disruptions in people's lives, which we're now hearing more about that SNAP benefits and WIC benefits will be cut off on November 1st, which is a huge change for most Minnesotans who use those services. We'll continue to hear more and more from the agencies as they receive federal guidance. I think part of the concern that we have is agencies don't know when they're gonna, turn to the federal government for a reimbursement or for a program that is typically funded and it just not be there because they're not receiving guidance on what will cut off and when it will cut off. So some of this is we're learning as we go in a really unfortunate way. 2 weeks notice to know that your SNAP benefits are going to disappear is not enough for people to make plans to figure out how to work around it. So we'll be looking into those actual impacts on Minnesotans.
Conversation today about the, I guess, sort of standoff happening at the federal level over those premiums and how they're going to increase and whatnot. I mean, what do you guys make of, as DFLers, the Democrats in the Senate specifically not wanting to pass something without guarantees that those premium benefits will continue?
I mean, first I'll say I can't blame them. Nothing that the Trump administration has done has said that this is a priority for them. Nothing that Congress has done has said that this is a priority for them. They could have included it in H.R. 1 if they wanted to, and they didn't. It was a choice that they made. Secondly, I will say we've been in a trifecta. We had a trifecta, and we understand that there are some bills, like a bonding bill here in Minnesota, that if you want to pass it, you have to negotiate with the minority party. They're not coming to the table to negotiate. President Trump has said to leaders in Congress not to negotiate, and so far it seems like they're following that line. If they won't negotiate, like, that is how government works. When you need the votes, you have to earn the votes. You have to talk with people, you have to compromise. And so far, not even being willing to have a conversation does not give me a lot of hope that this is going to end anytime soon. And I think we all appreciate our legislators, our senators, standing up for Minnesotans who told us today they cannot afford insurance if these premium tax credits are not saved.
What do any of you feel about what you heard from Republican colleagues today? Lines of questioning, maybe the comments made toward the end there. Thoughts on their stance?
You don't have to be.
I think we heard the same thing we heard last week. A lot of changing the subject, a lot of deflecting. At no point in time did any of our Republican colleagues say, yeah, we should push our partners at the federal level to not cut these tax credits. No one said that. Instead, they started talking about the ACA in 2010. They started talking about fraud, which is the usual talking point. Removing health care from 200,000 Minnesotans is not the way you fix fraud. And so, unfortunately, I didn't hear a lot of hope coming from our colleagues here today.
You mentioned a little bit about, Minnesota being, I guess, maybe an example during a trifecta of working across the aisle, that sort of thing. We did hear from Senator Nelson, and I hope I'm not misrepresenting this, but she said something along the lines of, we should see the Democrats in Congress just pass a clean CR. I mean, how do you feel about that coming from her, given what you had just said about the trifecta a couple years ago?
Yeah, I mean, I think we have realized, Democrats in Congress have realized that these costs for Minnesotans are too high. The burden on families, on businesses, on hospitals, with all of these cuts, not just the enhanced premium tax credits, but also the cuts to Medicare and Medicaid that we heard from our hospital systems that will be devastating over the course of the next 10 years. Without making changes to those, just the cost is too high to the state of Minnesota, to states all across the country. I think that when you're in the minority, I've also been in the minority, you have very few tools. You have very few places where your vote matters. And this is one of them. It is one of the few places where a minority party can force a majority party to come to the table and negotiate. And that's what Democrats in Congress are doing. I think they're doing it for the people of this country who deserve to have health care, they can afford, for the hospitals in rural counties that will close because of these provisions. It is a hard decision always to hold the line, to put your foot down and say, we can't do this, we can't. But as we heard today, we can't do this. People cannot afford these costs. They will lose health care, and Senator Rest is right, they will die. People will die because of these provisions. And for me, standing up to ensure that people have access to healthcare, to ensure that there's a path for rural hospitals to not close, to ensure that people have just the simple dignity of being able to go to the doctor is a worthy fight.
My last question, in case I think of another one here. You guys have had, we're still kind of in the infancy of this subcommittee here, but we've had a couple of meetings now. Realistically, at the state level, there are a lot of things happening in the federal government right now, a lot of these bills that you guys have been talking about, but what can be done at the state level by you guys, by your colleagues across the aisle, by the House, to respond to some of this?
We have big challenges ahead of us. We had big challenges ahead of us before HR 1 was passed, and now we have bigger challenges ahead of us. I hope that we come into this legislative session with creativity and a new sense of we cannot just put Band-Aids on these problems. We already had problems that were too big for Band-Aids, and now they've been blown wide open with Congress's actions. So, we need to come with an openness to find new ideas. That's part of the reason for this committee, is to really spell out the breadth of the problem. This is not something we can fix by just, going back to a high-risk pool. Are you kidding me? That's ridiculous. We need to have a different vision of how people can receive care in this instance. We need to have a different vision of how people are cared for in our emergency services, like SNAP, like rent stability, rent assistance. We need to think through, what are the ways that we as state government can reimagine what can happen? And I think some of that also might include partnering with fellow states who are looking to, partner together now that we have a federal government that we cannot rely on as a stable partner. So I think all of those are on the table. We need to have conversations about them as legislature, but this cannot be a business as usual session or we will fail Minnesotans. We have unprecedented, I know that word has been overused a lot in the last few years, but this is unprecedented to have a federal government that is actively hostile to the state's programs that the federal government is supposed to support. And we have to come in with fresh new ideas about a better vision for Minnesotans.
I want to add one more thing about her committee. Senator Port and the Select Committee aren't going to find all the answers. It's partly for us gaining information for the public, for ourselves, so we know how to respond to this. But as Senator Port said, this is unprecedented. She said it was the first time federal government's actively going after states and state programs. It's the first time federal government's actively going after American people, actively going after people who are most vulnerable and taking away stuff. And we're trying to figure out how to do it. So I think the first thing we need to do is hear more, and that's what this committee's been doing and getting lots more information. Do any of us have ideas how we're going to deal with this, how we're going to minimize the pain? That's what we're trying to figure out, and I think the committee is extremely valuable in that.
Well, I know you guys have a bunch of other reporters here, so. Thanks, guys. Appreciate it.
Those who show up get to talk.